Welcome to the Food as Medicine Summit, Treating Disease, a collaboration between the Center for Food as Medicine and the Hunter College New York City Food Policy Center. Please welcome our host, Dr. Charles Platkin, Executive Director of the Center for Food as Medicine.
Good morning, everyone. I want to thank you so much for coming to our Food as Medicine Summit, Treating Disease. My name is Charles Platkin, and I'm the founder and director of the Center for Food as Medicine. The Center for Food as Medicine is a global nonprofit working to bridge the gap between traditional medicine and the use of food as medicine in the prevention, treatment, and management of disease, while also increasing access to healthy, affordable food. The goal: to create a more equitable food system that will improve individual and population health. While diet has the potential to cause or to prevent disease, it also has the capability of treating disease, thus building, maintaining, and restoring health. We are very fortunate to have several experts join us today who will offer their invaluable insights and experiences in the field of nutrition and health. These experts come from diverse backgrounds, including medical doctors, nutritionists, researchers, and policymakers, all united by one common goal: to explore and promote the role of food as a key factor in improving health outcomes. This summit is a testament to the growing recognition of the importance of diet and nutrition in healthcare. Today's panels will cover a wide range of topics, from the role of food and dietary supplements in treating disease and depression to debunking common myths about food and cancer. We'll also delve into culinary medicine training for healthcare providers, a crucial step toward integrating food-based treatments into mainstream healthcare. Lastly, we will explore the pivotal role of food as medicine policy, a key panel that underpins the integration and success of the diverse topics we're discussing today. Additionally, we are deeply grateful to our partner, the Hunter College New York City Food Policy Center. Their collaboration has been instrumental in making this event a success, and their commitment to understanding and improving food policy aligns perfectly with our mission at the Center for Food as Medicine. Together, we stand at the forefront of a transformative movement, one that recognizes and harnesses the power of food as a tool for healing and wellness. We hope that today's discussions will not only enlighten you, but also inspire you to become advocates for this vital cause. Thank you once again for joining us. Your presence here is a valuable contribution to our shared vision to a healthier world through the power of food. Let's embark on this enlightening journey together and explore the remarkable potential of food as medicine. Thank you and enjoy the summit.
Coming up, we kick off the Food as Medicine Summit with a keynote from Dr. Dariush Muzaffarian, cardiologist, professor, and director of the Food as Medicine Institute at the Friedman School of Nutrition, Science, and Policy at Tufts University.
I'm really pleased to be here with you virtually. I regret I couldn't be there in person. I have a great fondness for New York, having gone to Columbia for medical school and lived in New York for several years. And so it's really exciting to be talking about food as medicine at the Hunter College Food as Medicine Summit. This is a really important area that's rapidly accelerating in interest from payers, from policymakers, from doctors, from patients. And so I want to just speak with you about, my impressions about what's going on, what's the current innovation, and what are the future directions in food as medicine. The first thing to really think about is just to recognize how sick we are as a nation from diet-related diseases, why food as medicine is so important. Today, more American adults are sick than are healthy, many, many more. Half of all adults in our country have diabetes or prediabetes. Think about that. Half. of every single adult in our country has diabetes or prediabetes. 3 in 4 have overweight or obesity. And if you combine that with blood cholesterol levels and blood pressure, 14 out of 15 adults in the United States have suboptimal cardiometabolic health. 14 out of 15. So it's truly the rare person who's walking around healthy. And I think this is really making us all feel sick and walk around feeling sick. And most Americans maybe don't even realize that how sick that they feel and how this is hurting their mental health and physical health. And this starts young. Among American teenagers, 1 in 4 American teenagers has prediabetes. 1 in 4. 1 in 4 have overweight or obesity, and 1 in 6 have non-alcoholic fatty liver disease. Now, there are also, of course, stark disparities in all of these statistics. So folks who are rural, lower income, lower education, from Black or Latinx or indigenous backgrounds, all have even higher rates of these conditions. It's really incredible. And if you put all this together, much of this is due to poor nutrition. We and others have carefully quantified the burdens of cardiometabolic diseases specifically attributable to poor nutrition. And we've estimated that 10,000 Americans are dying every week directly from poor nutrition, 10,000 Americans a week. And there are 21,000 new cases of diabetes every week directly attributable to diabetes. In sum, almost half of all cardiometabolic disease events and almost 70% of all new cases of diabetes are attributable to poor diet. Now, this is where food as medicine is really important. And there are different ways to talk about food as medicine and different definitions. I think of food as medicine as integrating food-based nutritional interventions into the healthcare system to treat disease and advance health equity. So all 4 of those kind of elements of the definition are important. It's about food-based nutritional interventions, not supplements or just dietary counseling, but food-based interventions. It's integrated into healthcare for the first time really in my career. We actually are having these interventions integrated into healthcare. It's to treat disease, not just to think about long-term prevention 20 years or 30 years from now, but to actually treat disease. And it has to also advance health equity, and we'll talk about each of those issues. And so the first question is, why do we care so much about integrating food into health? I've told you about the incredible challenges in disease and disability and health disparities from poor nutrition. But we have to sort of turn to what the newest science is telling us about where are these burdens coming from. Starting around 1980, we were really taking a serious look at diet-related diseases in this country. And the major recommendations to address those were to reduce the bad things: less fat, less saturated fat, less dietary cholesterol, less salt, and so on. And while, of course, excess salt is harmful and excess added sugars in beverages are harmful, we've learned since that while there are, of course, negative things in foods that we have to reduce, most of the disease burden in our country and actually around the world is not due to excess intake of harmful factors. It's due to insufficient intake of protective factors. So we really need to increase the good. What's missing is causing more disease than what we're eating too much of. And so these include foods like minimally processed fruits and nuts and fish and other seafood, vegetables, plant oils, minimally processed whole grains, beans and legumes, yogurt. All of these foods are being eaten, at too low levels. This is a very important positive message about food. It's a positive message for patients. It's a positive message for farmers. It's a positive message for retailers and food manufacturers. We don't just need to demonize and think about food as something negative. We need to celebrate its nourishing aspects. And this is what food as medicine does. Food as medicine really looks at these protective foods: fruits, nuts, vegetables, beans and legumes, plant oils, fish, yogurt, whole grains, and gives them to patients in need. And so I think that's really a critical positive message about food as medicine. Now, I think of food as medicine as a pyramid, and we've published this pyramid, where at the top of the pyramid, you have the sickest patients who need the most intensive interventions. And at the bottom of the pyramid, you have the broad population who need broad population-based food as medicine interventions. And so what are these different levels of interventions? At the top, we have medically tailored meals. And medically tailored meals are for patients who have multiple comorbidities, complex illness, things like very poorly controlled diabetes, end-stage renal disease, heart failure, other cardiovascular disease, cancer, HIV, severe lung disease, and so on. These patients arrive to hospitals and doctors' offices and emergency rooms malnourished. They depart malnourished. They have a very high risk of rehospitalization. They have a very high risk of not being able to return to their home and have to be admitted to a skilled nursing facility or other institutional care. And so medically tailored meals are really sort of the tip of the spear for patients. And we'll talk about those. I'll talk more about those in a minute. Then below, the next level of the pyramid are medically tailored groceries and produce prescription programs where people have diet-related diseases but aren't so sick and malnourished that they're unable to shop and cook. They can shop, they can cook, and they really need healthy foods, but they can get them in the form of groceries and produce prescriptions. The next layer of the pyramid, which is really important also to integrate into healthcare, is to leverage the federal nutrition programs. SNAP, formerly the Food Stamps Program, WIC, which is for pregnant and nursing women and young children, and school meals for school-age kids. Those federal nutrition programs can all be very important to improve food security and also, if done right, improve nutrition and improve nutrition security. And then lastly, at the bottom of the pyramid are population-level healthy food policies and programs, things that support everything else, things that support the medically tailored meals and groceries and produce prescriptions that support the federal nutrition programs. All of this has to be integrated with nutrition counseling and culinary education, not just nutrition education, but culinary education. Now, the depth and intensity of that education remains unclear. Most patients who are offered, one-on-one RDN counseling don't use it, and we've seen that in a recent randomized trial. Only about 20% of patients used an RDN, and only half of them used it more than once. Half of that 22%. So most people, don't have that need to see a one-on-one RDN. For those that do, it's excellent, and an RDN can be very powerful. But we need to, I think, have more digital and scalable interventions to reach people where they are more quickly, more rapidly, more efficiently. So that's sort of the scope and scale of food as medicine from the top of the pyramid to the bottom. Now, medically tailored meals, I think, are really exciting because they not only improve food security and nutrition and health, they actually reduce healthcare spending. We've done analyses suggesting that if the roughly 6 million Americans in our country who might be eligible for medically tailored meals all receive them, if they all receive medically tailored meals, about 10 nutritionally tailored meals per week for an average of 8 months per year, even accounting for the program costs, this intervention would save money because hospitalizations are reduced and emergency visits are reduced. And so total healthcare costs are reduced by about 20%, even accounting for the cost of the program. We estimated a national program of medically tailored meals that was covered as a covered benefit for patients with complex conditions would reduce annual hospitalizations in the United States by 1.6 million hospitalizations, and it would reduce net healthcare spending in our country by $14 billion. And so this is really kind of a no-brainer to implement medically tailored meals. And there's a bipartisan bill that's been introduced in the Senate and similar language in the House to test and implement and pilot medically tailored meals in Medicare, which I think is really important given, most Americans are covered by Medicare. Now, I mentioned produce prescriptions, and so that's the next level down in the pyramid. And we recently published a paper on about 4,000 people across 22 sites in 12 states. Now, these were not randomized interventions, but what we found is that after 6 months of intervention, produce prescriptions improved fruit and vegetable intake by about a serving per day, improved self-reported health by 60%, reduced food insecurity by 36%, improved hemoglobin A1C, improved blood pressure, and improved body mass index. And so really powerful evidence that these programs work. And just this week at the American Heart Association meeting, my collaborator, Claudia Now from Kaiser Permanente, presented the results of the first large randomized controlled trial of produce prescriptions, which we implemented and completed in Southern California, along with FoodSmart and the George Institute. And we showed in a randomized controlled trial among low-income Americans with diabetes, that produce prescriptions significantly lower hemoglobin A1C. And so we have the evidence now to begin to implement these interventions. And now, while I think there is incredible power in these interventions to advance nutrition security and advance health equity, I think there are also questions, and this is where the field is going. So we talked about the innovation, the excitement, but there's a lot of questions. What are the optimal foods that should be covered? Is it just fruits and vegetables? Should protein foods be covered? What about nuts and beans and legumes? My own belief is that we need to cover the foods that I mentioned before that are clearly shown to be healthy. There's also questions about the dose. It's not really clear that more is better. Most programs might give $40 a month or $50 a month of produce prescriptions, and it's not really clear that doubling that has a significant additional benefit. So we really have to understand the dose. We also have to understand the duration. Many of these programs only go for 6 months, and I think that it's very likely that many patients will need prolonged treatment, just like we give prolonged treatment for blood pressure lowering or for cholesterol lowering. With food as medicine programs, we also may need to give prolonged treatment. Other patients may just need a few months or 6 months of treatment and then are better and don't need more treatment. So I think that's very, very important. We have to better understand the role of nutrition culinary education and how to deliver that efficiently to reach patients. And I'm guessing this is going to be a range of different options for different patients who respond, some digitally, some in person, some in group education and other ways. We have to understand the importance of family sharing of the programs. If you give $50 a month in healthy produce to a single person versus a family of 5, it's likely the food will be shared in the family of 5. And so how do we account for that, and how do we consider that? I think there's really interesting questions about how to get the food to people. Should they pick it up in a physical brick and mortar a grocery store in the healthcare setting? That's being done. Should they get a card and go buy it themselves in the grocery store? That's also being done. Or should they get online delivery? And personally, I think that the intervention that will reach the most people will be online delivery, because that also deals with issues of time and transportation and food access. There's many other questions about doctors' education, how we educate doctors about these things, costs and cost effectiveness, how these programs link to other new drug treatments like the GLP-1 agonists that are effective for weight loss and much more. So I think it's a really exciting time for food as medicine. There's enormous attention from policymakers in the federal government, from policymakers in states, from private healthcare payers like Elevance and Kaiser and Geisinger Health and many others. 9 states now have active food as medicine programs in Medicaid, either approved or about to be approved as pilot programs. New York is about to have one of the largest ones approved, if you're not familiar with that, which is really exciting. And so, the genie is out of the bottle. The genie of having nourishing food be a tool in the toolbox of doctors and other allied health professionals is now a reality. And so I think it's an exciting time, a lot of work to do. And we're really excited at the Food as Medicine Institute at Tufts to be working on solutions with researchers, with policymakers, with the healthcare system, with community-based organizations, and with people in the community who care about these issues. So thank you for letting me come and speak to you a little bit about food as medicine, and I think the exciting times ahead, and look forward to working together to make this a reality for more Americans.
Welcome to those of you just joining us. Our upcoming panel explores food and dietary supplements treatment for depression. Get ready to gain valuable insights from our experts, Dr. Uma Naidu and Dr. Drew Ramsey with Dr. Charles Platkin. Stay tuned.
Gary, what a wonderful keynote. I'm so glad you were able to make it today and offer those inspiring words. Dr. Ramsey, Dr. Naidu, thank you so much for joining us today. To begin, I wanted to delve into the prevalence and impact of depression and mental health issues in the United States and around the world. Could you kind of clarify some of these things and give us some more understanding?
And Charles, I was actually interested that you chose depression, and I think I do understand why. It is a very, very common disorder, and I think it's a leading disorder that leads to disability worldwide. But it turns out that anxiety disorders have increased by 25% after COVID. A study published in Lancet showed that after COVID-19, anxiety disorders grew from about 298 million people affected to about 374 million people. But I think even Dr. Ramsey will agree that when we treat individuals, there's so much overlap between depression and anxiety. But I do want to point out that there is that subtle difference that anxiety is urgent, but very often even the treatments, as you know, pharmacology and psychopharmacology-wise are very similar. So I think that I'm really grateful that you are drawing attention to this.
That's great. And so Dr. Ramsey, do you have an idea of what the scope of depression is in terms of, and also what's the difference between clinical depression and just being sad, or, hey, I'm depressed today, or in fact, last night on my phone with my daughter in college at Cornell, she was saying how she's depressed and, and she has high anxiety. So what does that translate to?
Well, I think from Uma's new book, it translates to some great menu items. And I think from the research, it translates directly to her college cafeteria. I think in terms of and we'll talk about some of that research later, in terms of scope, which I think is your question, mental health disorders are, I would say, worse, bigger in terms of an issue epidemiologically for us worldwide. That question you have, like, what's the difference between depression and feeling blue? Boy, it's hard to know these days. We have our diagnostic criteria, but I think going on with what's going on in the world between COVID, the Ukraine war, the Israel-Hamas conflict, I think everyone's really struggling with their mental health and more interested in it than ever. The reason we're facing, I think, a different battle in mental health is the disorders strike earlier. We mentioned depression and anxiety. Those are the ones we like to talk about. We have a lot of colleagues, former colleagues from OMH here, where I worked for years. We have to remind ourselves 1% of the population has schizophrenia everywhere. Right? And so when we look at the top 10 drivers of disability, as Uma notes, depression is number one, but we have suicide, alcohol use disorder, anxiety disorders. And so with facing one, the stigma, two, stigma about treatment. It's pretty easy to treat depression. Maybe not everyone responds. Let's say 60% to an antidepressant. 60 out of 100 people whose depression is treated for $10 a month with an SSRI. That's not optimal treatment, but for some people that certainly happens. We have so much stigma. So we face stigma in terms of the numbers, as Uma notes, that they're getting worse for a lot of reasons that we'll talk about. And I'm excited to be with you to talk how food and modern nutrition is driving some of this and part of some of the solution. But big, growing, stigmatized, and difficult to treat, and then a lot of misinformation that all of us in mental health know that we're facing.
And in terms of looking at food and dietary supplement treatments, we know there's psychotherapy and we know there's pharmacology. Is this an integration? Is this because I think a lot of people think about this when they think about treating depression and anxiety. They think about, I could just take a pill, and some people just don't want to take a pill, right? They don't want to go to psychotherapy. They want to simply take dietary supplements that they see on TikTok, or they hear from a friend that omega-3 is going to impact you. How does this? Is this so? Again, in your view, you're the two world experts on this topic, okay? And we'll get to know what nutritional psychiatry is in a moment, but. How does this work? Again, is it an integration? Is it a this or that? Can it be a this or that? And I'll leave it up to you two to let me know. We could start with you, Dr. Uma.
I think that's a great question, because I think it's not something that many people understand, because most often traditionally, if you're seeing a psychiatrist or mental health provider, you're getting a prescription medication and hopefully also getting counseling as well, because I think the two are very important. I founded and direct the only academic center clinic in nutritional psychiatry, nutritional and metabolic psychiatry in the US. And the principle that we really based our care on is an integrated and holistic approach, with also looking at functional causes for what's going on with the individual that we're assessing. And the reason being that this is intended to work alongside any other clinician referring a patient to us, any other situation or clinical condition that person is experiencing, and it's meant to be an integrated approach. It's not meant to be an either or, and the reason I say that is we have to be careful in mental health. Suicide is a huge issue, and these days people are incredibly lonely and suffering in a very different way post-COVID. So I feel like one of the things we want to separate out and distinguish is that when someone is acutely mentally ill and meets criteria for being in an emergency room or needing acute emergency care, while nutrition can always be extremely helpful to them, it's not going to be the leading thing that we offer them, because they may need actual acute treatment to stabilize them for their safety, etc. But the rest of the time, everyone can actually benefit from these alongside whatever else they're doing. And there are also a large cohort of individuals now who are coping, but really need some tweaking, and they realize the tweaking of their diet, because they realize that nutrition is playing a role in this. They've understood the connection, and so they're coming in really just to work on that. So my clinic covers all of those spectrums of things, but we always work in an integrated approach.
And yeah, sorry, Dr. Ramsey. Well,
people call me a nutritional psychiatrist, but also I think I'm an integrative psychiatrist. I'm primarily a psychotherapist in a lot of ways. That after doing this for 20 plus years, I really like sitting with people and getting to know them very well and understanding how food plays a role in their life and in nourishment. I think we want to kind of take one step back and think that food isn't a treatment. Food is a foundational piece of our mental health, and we've not considered it that. We encourage people to eat foods that are bad for the mental health. We have a culture that's obsessed with foods that are bad for our mental health. And we revolve kind of working with food in a culture that is just now starting to think about mental health. So the idea that we have data, like we have criteria or recommendations from the top experts in nutritional psychiatry to prevent depression. And when we think about who are the, where are the top places, like shouldn't that at least be 15, 20 minutes, half an hour on every college campus? Right? The president of the college comes to the cafeteria and says, hey, everyone, there's French fries here, there's burgers here, but we've also got this Mediterranean corner because of this data saying you all are going to struggle with your mental health over the next 4 years, and we want to prevent that in some way. We don't know if this is going to work, but we want to try. We need your help. We need you to engage. When we do that, and when the researchers look at that over the next, when they integrate a food program into college mental health, there's a significant improvement in prevention of mental health disorders. And so in terms of how we integrate, I think first is understanding we don't want to think about nutritional psychiatry as treatment first. We want to think about it as prevention and lifestyle around mental fitness first. And then I think in terms of treatment, how do we integrate it? One is that we have to understand a lot of mental health care is not happening with me. I'm a private practice psychiatrist. I was at a top academic medical center. We both see patients a lot, but a lot of mental health care advice, as you know, is given in TikTok, is given by college counselors, high school counselors, pastors. A lot is given by fitness coaches and trainers. And so part of our work at the Brinkfield Clinic in developing some early trainings in nutritional psychiatry, we trained a lot of psychiatrists. We like that. We also trained chefs. We trained people who worked in schools. We trained nurses. We trained some OTs and PTs, people who are talking with patients and trying to make an impact, but they wanted to integrate some nutrition advice that was based in more science around mental health. And so I think one, gets integrated a lot of places. And then my favorite place we integrated, the first one was Christina Mangurian, who some people know as vice chair at UCSF, but way back when Christina was a public psychiatry fellow at the Audubon Clinic. We integrated it at the Audubon Clinic we served lunch at our day program. And we sat everyone down and we said, food and mental health are related. A lot of people are struggling with metabolic syndrome. What can we do differently at lunch? We had a little focus group, and we started adding in more brown rice. We started adding in more veggies and more rainbows. And we started trying to at least have nutrition be, one of those things. It's not the only thing. I think people make that mistake. It's not all gluten, right? Gluten's interesting, but that's not the whole thing. And so we want to integrate appropriately, and we don't want to mistake it for it works for some people for treatment, but it's a part of treatment.
And just stepping back slightly, because many people in the audience may not know the term nutritional psychiatry or nutritional psychology. Can we come up with some sort of broad sweeping definition? I mean, you kind of touched upon it, that it's an integration, but it's really a new term for many people. So
it's a new term, and I think we also find a little bit, for me, because I'm a food guy. I'm here on this earth to help you eat zucchinis and lentils, and I like the data about omega-3 fat, but what I really like is your anchovy recipe. And so I define nutritional psychiatry as it's the use of food to optimize brain health, because I like this idea that it's 5 out of 5 out of us. It's not 1 out of 5 people have mental illness. It's that all of us have brains. They're a little fragile, especially these days, and they all need better nourishment. And then in the treatment and prevention of mental health concerns. And I like calling it concerns, because what I find really fascinating about this work is I'm talking to all kinds of groups that as a psychiatrist, they'd never invite me to talk about depression or anxiety. No one who's going to ask you like a wellness hour at a fancy bank or whatever. But when it's like foods to fight anxiety, foods to fight depression, foods to optimize our mental health, people are interested. And then we're having a conversation about mental health, and where and I can layer in a lot of psychoeducation about how to take care of yourself.
Right, and that's part of that integration. Sorry.
Yeah, so I totally agree with that. And I think that I see nutritional psychiatry not at a point of being prescriptive yet, but I also have the hope that as we do the ongoing research, we've just recently published a few days ago a paper on the use of omega-3s in a trial that we did. And I think that as we commit to doing more research and as we commit to doing more clinical work, nutritional psychiatry continues to be at that integration of the use of healthy whole foods and nutrients to improve your mental well-being. And when I say prescriptive, what I'm referring to is the hope that as we try to bring the food as medicine movement forward, especially in the United States, and especially as we continue to train more clinicians, we released a course in nutritional psychiatry at Mass General, and it's really intended to be for, and it's CME accredited, to be for any clinical person. It could be of any specialty. It doesn't only have to be a physician, who can learn to integrate at nutritional psychiatry 101 at the basic level, how to integrate this into clinical practice, because we have to start somewhere to grow the movement, right?
And what does that look like? Because I'm just going to go through some of these things in just in my notes that for here for a second. So epidemiological studies have consistently demonstrated a link between nutrition and mental health. Systematic reviews highlighting that healthy dietary patterns rich in vegetables, fruit, whole grains, nuts, seeds, and fish, and limit processed foods are inversely associated with risk of depression. Diets, we just did a whole segment at the Center for Food as Medicine on ultra-processed foods with Kevin Hall and Marion Nessel, which is anybody could see on YouTube. And there's a direct link between ultra-processed foods and mental health issues, such as depression, anxiety, and so forth. Deficiencies in essential nutrients like B12, omega-3 fatty acids have shown to impair mental health and cognition. And so when we talk about prescriptions and also and how we integrate this and how psychiatrists integrate this, and Dr. Drew, how you talked about just before, in a cafeteria, coaches, there's so much out there. How does this get into healthcare providers' hands? The research, when I just did 5 months, I'm working on a new book on food as medicine. I just looked for 5 months on anxiety. And I'll tell you, it was not an easy task, scouring through the research. And it was confusing I had 4 research assistants working with me, and it was confusing. And it was confusing, we looked at impact factor, which for those that may not know of a journal is its credibility factor, or loosely defined version of its credibility factor, how many citations an article has, who wrote the article, whether they were funded by the food industry, and all those kinds of things that come up. And, it takes a lot of experience to be able to scour through that. The layperson doesn't have the ability to do that. So it's expected that experts do that for them, like you and Dr. Ramsey and you know, Dr. Naidu. So how does the layperson do this? How do coaches do this? How are academic institutions supposed to impart this wisdom on their students? How a medical school is supposed to impart this on their medical students? And now I'll shut up because I could breathe through the whole hour talking. So.
Yeah, that is a really great question. I think the public and even clinicians being able to distinguish and tell apart proper research and proper researchers, proper data from stuff that's just on the internet. It feels a little bit these days, I don't know if Drew is experiencing this as well, but I feel like anytime I am looking at something on social media or on the news, everyone is talking about mental health. And it's so important, for reasons that we've outlined already, to actually go to mental health providers for mental health, because, you know, unless you've counseled someone off a roof, unless you've actually dealt with actual suicidal ideation and worked with individuals who have been in the depths of psychosis, and you've been trained and you understand that there are ways that you can counsel and help them, you don't really know mental health. And I say that with all due respect to everyone who is actually trying to bring the work and support towards those who are struggling with mental health. But I think the worry I always have is that if you're not trained and you don't have that knowledge, you may miss something that is clinically really important and could mean the difference between life and death for that individual. You know, something like an eating disorder can be lethal in a person. And one of the things in nutritional psychiatry that I have to be very careful about in my clinic is that someone who has a healed eating disorder can certainly use nutrition as a positive strategy. But someone who's in the depths of severe anorexia, for example, is unable to really use the nutritional strategies that I can provide because their difficulty is really that relationship with food. And that condition can actually be lethal. Many people don't often realize that. So I think that when you are looking at research or you're looking at a training program, you have to look to see if they're well-vetted clinicians, if it's from an academic center, because when you create a program at an academic center, let me tell you, about a year of that preparation is going through all of the different levels of academic committees to approve the content that you're putting out, what you're actually saying in your videos, the editing that goes in. And so in order to then create the CME credits for clinicians of different disciplines, they assess all of that. So that is usually a pretty decent standard to go by. When it's a research article, I think you make an excellent point. Always look to see the conflicts of interest, because if the article is about artificial sweeteners and it's funded by Diet Coke, there may be a conflict there. So you want to make sure that the researchers and their funding is clear of conflict. And when it comes to social media, you really have to vet the source of the information very carefully. And I think that's where I worry about teens and younger folks and those who are, say, not in the clinical world, like many of the people attending this, who may not be able to tell that apart because they're very vulnerable.
Right. And Dr. Drew, just before you go, I just want to read this, and then I would like you to respond to it. It's similar, but I wanted to read what I had, the original question I wrote, because I'm doing a lot of this just extemporaneously. In an era heavily influenced by social media, the prevalence of quick-click headlines and influencer-driven content makes the accurate interpretation and evaluation of information about food as a therapeutic tool both challenging and crucial. Many influencers lacking in-depth training may not fully explore the extensive research when recommending diets related to mental health issues. Additionally, I observed that once reputable magazines, because every week I do a news and research digest that goes out to 115,000 people. And that research digest, I see like Sports Illustrated, Discover Magazine, Time, Newsweek. They're using clickbait, basically. And most of it is around mental health issues. So I noticed that they have articles about lists of supplements that'll improve your mental health and decrease your chance of Alzheimer's, all with a lack of research. And, and experts in the forefront, as you two are experts in the forefront of psychiatry, nutrition, culinary arts. What advice, and this is where it's a similar question that I just asked. So I'll leave this to you, Dr. Ramsey.
Well, thank you. I think that there's Uma makes a lot of great points. I probably disagree a little bit in the sense that I am prescriptive because I'm a clinician sort of out in the world, not centered primarily in academia. And so there's a way that everybody I meet for the last maybe 15 or 20 years, I ask them about everything they eat and I give them some ideas based in whatever research is emerging. Since I started doing this, there have been 7 randomized clinical trials, all small, finding significant improvement when people are given mostly a Mediterranean diet. And so I think one of the things that we're struggling with in mental health and in food and mental health is that a lot of it is very straightforward. It's inexpensive, it's simple food, it's not based in superfoods, it's not based in anything that's that complex. If you look at the criteria for the prevention of depression, which you'd think everyone would be fascinated, interested, like how can we prevent depression with food? None of it's going to surprise you. Right? Eat more vegetables, eat less processed food, eat some seafood, eat whole grains, right? Simple advice. And so sometimes I think that because we're in such search for data to tell us what is very simple, people have started radically changing what humans eat. We eat a lot too much, and we eat the wrong food categories. And in terms of what to do about it, I think we all have our own calling. You know, I've been just blown away that Uma is the only nutritional psychiatrist with that phrase in America in an academic appointment. Others of us, you know, I've been singing and dancing on social, no dancing, I didn't get to TikTok, but I've been on social media since the very beginning. I got the APA to join Instagram. I got Columbia Psychiatry to join Instagram with the notion that if we do not get mental health messaging out there to give somebody at least an alternative, we're not doing our job. We can't explain mental health in a cool visual picture or and it's been amazing over the last 15 years to see this huge growth that does a few things. One, it shows the diversity of mental health. When I look at the influencers on mental health on Instagram, it is such an incredibly wonderful, creative, diverse group of individuals. So I think we're seeing more of that. That's sort of, I think, one way of how do you battle it? Well, we all try and do our part in some way. And I think we all have a little bit of a different role. I think the other places that academic places should wake up a little bit to all of the potential, I guess it just leads to conflict of interest, but all of the interest in this idea and all of the potential funding, you know, that academic centers, by and large, have subsisted on government grants and big pharma grants. And, you know, the other big pharma with an F is really, just like big pharma with the PH, both concerning, but also has some concerns, also a huge industry with lots of funding that's really interested in understanding how its products can work and optimize human health. And so I think, Stanford now has a metabolic center funded by the Bazooki Foundation. Uma has her center. The Food and Mood Center in Australia is probably the most robust international center. You know, you have Felice Jacka. Felice Jacka already has 24 publications this year.
She was going to be here, but I think it's 3 a.m. now.
I mean, it's
wow. I couldn't make her come here at 3
That's
a.m.
tight.
I mean, I'm surprised she didn't, because she has been the tip of the spear in terms of driving nutritional psychiatry. She and Michael Burke, I think. Those are some of the ways I think that we see the change happening, that institutionally people stepping up, thinking about creative funding sources, getting involved in messaging and content creation, right? There are 3 or 4 courses now where people can get training. There's UMA's, the Food and Mood Center. We launched ours in 2018. There's one at Kennedy University, has a nutritional psychology course. So there are places, and there always have been, where you can get this information. I think that the challenge is that the glitzy algorithms like things that, a lot of us don't do. I keep my shirt on social media. I don't show off my 6-pack to show you how amazing nutritional psychiatry is.
There's a lot of stuff of that going on.
Yeah, we don't.
Interesting.
Yeah, we limited patience. We have limited time to make the best video. So.
Right. Well, I think to Drew's point, one of the things that we've managed to do successfully is really use social media in a positive way, and use it for educational messaging and working with organizations that help to promote that positive mental health messaging, reduction of stigma, and also how do you use food and nutrients in an everyday way. I always see Drew and his recipes, or sharing on food. And I think it's important to assess the account that you're going to, assess the information, where it's coming from. Because the reality about nutritional psychiatry and research behind it, the reality of psychiatry itself, based on DSM-5 TR now, is that diagnostic criteria are very different from other conditions. When you need knee surgery, or you need you have a lung infection, and you can actually get a culture and test to see what it is we need to treat you with. It's very different in mental health. We don't have a brain biopsy. We don't have those types of diagnostics. So one of the things I first and foremost want to point out, the positivity of the niche that nutritional psychiatry fills, is the fact that DSM-5 TR does not cover it all. Those are diagnostic criteria used to guide mental health clinicians, but it really doesn't cover every human being. And the other thing is that our research is well done, and we look for the best type of research, but we're also largely looking at group data. And unfortunately, the N of 1, and when you're seeing a patient who has a very different reaction to the same food to the patient that you just saw the hour before, you start to integrate the clinical and the research. And I think that that's something different that I think Drew and I each do. Seeing people in lifetime and making sure we have dependable research to go to offers guidelines, but it's not the be-all and end-all, and it doesn't lead to being able to give someone that prescription. But it allows for really strong, well-researched, evidence-based guidelines as to how people can eat. We do tend to come back to a lot of the similar guidelines that, to be honest, people know how to eat healthy. It's really interpreting the food and understanding. It's actually led to a project that I'm working on in the UK. And I'll explain this because it was brought up by a very important person. The fact that people don't always understand why they understand healthy food, but they don't understand the reason that food is healthy and they need to eat it. I was invited to do a mental health plenary keynote last year at the Institute. It was a integrative conference in London, and 4 physicians from the United States were invited to meet at that time His Royal Highness Prince Charles. And in the conversation, what came up was that he is concerned about healthy eating, and also feels that people just don't understand what a healthy food is. And it's led to what we're developing to be the United Kingdom Food for Mood campaign with the College of Medicine, which always shocks me that we're not doing something in the United States around this. But exactly filling that gap. Broccoli is maybe healthy. You usually walk past it not me, but you might walk past it in the grocery aisle. But here's why you should eat it, and getting that to that point when someone is making a choice about food. So I think it's really important to put these factors together when we're making a decision, and to help people make that very best choice. And well-vetted influencers who are trying to do their best, I think, are great. But I do think we just need to check on the source as well of our information.
So I just want to shift slightly the conversation, because I know that a lot of people tuning in. We have thousands of people tuning in today. Did you want to say something, or?
Okay. You got a big audience for Food is Mood. That's just how it was. That's
so
awesome. Hey, everybody.
Think, both of you have books. You have Eat to Beat Depression and Anxiety. Dr. Ramsey, Dr. Naidu, you have a book coming up in December. I think it's being released, called Calm Your Mind with Food: A Revolutionary Guide to Controlling Your Anxiety. And those are available on every bookstore. You can pre-order Dr. Naidu's book. So I want to get down to some what people are interested to know. Okay, is what can I do right now? Are there dietary supplements? I mean, I'll be honest with you. After my research on anxiety for 5 months. I started taking a omega-3 fatty acid supplement, because I don't eat enough fish, and I thought it was important, right, based on what I saw, and I'm happier already. I'm just kidding, but I think that it's really relevant to talk about some of these details, like pre and probiotics. I think are critical. I'd like to go through all of them if it's possible. And also talk about dietary supplements versus food. And I understand that a Mediterranean diet is critical, but there are people that don't eat fish. There are vegans, there are vegetarians, and I just want to get into some of that. So I certainly want to talk about pre and probiotics, what they are, and I think they're referred to as psychobiotics, from what I understand. And
drinking some live bacteria for you right now, just to keep swilling some kombucha here at
Yeah. So let's talk about pre and probiotics first. And then I definitely want to get to omega-3s. I want to get to some vitamin and minerals that are lacking in our diet that could be supplemented. Let's get
Could we talk food category for just 1 second first?
Yes, absolutely.
Appreciate all the interested, but this is nutritionism. We're omega-3s are what's important. And the data on omega-3s, in my opinion, is not great. It's mediocre at best. It's statistically significant and clinically And it's great when people don't eat much fish or they want to try, because it's one of those ways that people start to engage, right? You're now asking, is your mood a little better? If it's not, maybe you're going to do something else. So that's one of the ways that I love that. But in terms of, I like food categories because I had a problem with kale. I launched National Kale Day. I wrote a sex book about kale. It probably ruined my academic career, but food categories, leafy greens, seafood, nuts, beans. It's a way to help orient people, because I don't care if you're eating black beans or white beans or lentils. Like, I can make little arguments on Instagram why one is better than the other for some reason. More potassium in white beans, right? But thinking about what's missing in Americans' diet is real food, and how to put it in there, I think, is around food categories. This is what all of the, if you look at the various scales like the ANDI or the antidepressant food scale, where you're looking at nutrient densities, right, you end up in food categories. So I have this little rhyme: seafood, greens, nuts and beans, and a little dark chocolate. And that's missing fermented foods and rainbows and some of the other really important food categories. But I try to orient myself and my patients that way, because it allows us to think, when we say pre and probiotics, what do you actually mean? And when it comes to food as medicine, there's only one prescription, and you only mean one thing, which is you mean plants and you mean fermented foods. And the problem is we approach probiotics and prebiotics and symbiotics and psychobiotics to the notion there's this thing I've got to take that then I'm going to grow these happy bugs in my gut. And that's not how live bacteria works. When I drink all this bifidobacter and lactobacillus, that's not what grows down below. Something else grows down below. My diversity increases. It's not of lactobacillus and bifidobacter. So when you're taking these strands thinking, oh, I'm putting that down there, the latest science says that's not really true. And so just to make the note, I'm happy to talk nutrients, but we always want to think food, right? And because I think people just get a little confused in the sense of omega-3s actually means a few fish. They're like 5 that you should really look for. And if we can help people focus on that, I think it helps them eat better.
The one thing I would say is that a lot of people hear those words. They don't know always what it means or what they mean. I think people are learning, and I don't expect everyone to know this. But they also, very often in my practice, will assume that they have to take a supplement for that. But to Drew's point, it's actually food. It's some really compelling research has shown things like inflammation. The group at Stanford did a study that was published in summer in 2021 showing that fermented foods, by including these in your diet, actually help to reduce inflammation. We know that inflammation is now one of the driving factors behind conditions like depression, anxiety, cognitive disorders, and more. That's been shown in research. So just a simple act of adding in a fermented food to your diet every day. Almost every culture has a fermented food. We just have to watch out for the added sugars, because some of the fermentation processes involve adding sugar. But even understanding that fact, and then understanding that incorporating foods like yogurt, kefir, tempeh, miso, and so many others can be helpful to your diet. I think going back to food principles and understanding that there is a reason to supplement when necessary, because a lot of us may be lacking certain things.
So you're not against supplements. You just would like to look at food first. That's food first, right? Is that kind of what? Because people like to boil things down.
I'm anti-supplement just because somebody's got to be. I think the supplement industry is totally horrible, and it's. I don't think people should take supplements in most situations. And I think our advice, multivitamin for an insurance policy, is like insurance policy against what? Not eating well, not moving your body, not being social and in relationships, not working on your health. Like, there's no insurance against that. Right? I mean, I totally agree in medical situations, but for the average person, I don't think the data has been robustly positive that multivitamins.
It's not. In fact, we just did something called the Everything Guide to Multivitamins, and I had a researcher spend about 75 hours pulling every research together. It's on our website, foodmedcenter.org. And we reviewed it, and look, I was disappointed because I wanted so much for a multivitamin to be something that I could just take and then when at the end of the day,
that why they exist though, that fear that you have,
yes,
missing something. And as opposed to us knowing where to then get those things, like, are you missing fiber? Are you missing folate? What are you missing? Omega-3s? Instead of us then knowing and translating that into food for ourselves and our patients, I think the reason that and I don't mean to be so contrarian, but the reason I want to just be anti-supplement for it is because it feels like trying to treat a fear that we should treat.
I hear what you're saying, Drew, but I also feel like that none of us eats a perfect diet. And I think that as Americans, where, the Western diet, standard American diet, which is called the SAD diet, is predominantly what people know. And I don't say that with judgment. I understand that this is just the way our food system and industrialization and marketing of food has taken us in that direction. Unfortunately, there are just so many people who lack certain vitamins. I'm with you on the multivitamin. I don't believe in the multivitamin marketing of gummies to kids. I mean, I just think a lot of that stuff is just frankly wrong. But there is a reason that people may need a supplement. Like in depression, there's a robust amount of research around saffron. We don't eat enough saffron in our food, even though it's delicious. It's just a few strands. It's very expensive. But a clean saffron supplement actually can really help mood. And some of my patients on their own have tried it with their children and anecdotally have found it to be very helpful in conjunction with speaking to their pediatrician. So I don't think we can exclude it. Here's another thing. In my book that I've written, Calm Your Mind with Food, I wrote a lot about micronutrients and micronutrients because I felt that these are things that people get confused about. Your point, Charles. And one of the things that people don't realize is there are many, many women and children who are iron deficient in the world. And iron deficiency anemia in infants, children, and teens actually correlates very highly with anxiety. And it's a simple thing. If we knew they were iron deficient, that we could either supplement or treat them or even give them enough foods that contain iron that could help them along. So these are just, I don't think we can understand, Drew, you need to take a position, but I feel I need to be open to that for certain individuals. A lot of individuals in the far northeast, where I live, are deficient in vitamin D. So we just have to make the case for food first, but there may be times that we have to step in and give someone an iron supplement, for example.
Yeah, and by the way,
I totally agree with that. I just think someone needs to wave the flag that it's our knee-jerk response. The evidence mostly stinks, and we're missing the piece of information that we're all here for, which is helping people eat differently. And so I totally agree. Saffron, omega-3s, vitamin D, there's a lot of stuff I use in my clinical practice, but it just feels like we answer that fear as opposed to really challenging ourselves to know that we're nourished.
Right, and to your point, and I totally agree. But again, I think that some of the things are like there's certain things in our diet that we're never going to get enough of through foods. Right? Is it magnesium?
What's it look like I'm missing? I'm just curious.
Is it magnesium one of those that's very hard to get?
Many Americans are deficient in magnesium without knowing it, and part of it goes back to this. Part of it goes back to our food system and the fact that, I don't know if you've heard this, that, friends and family or you yourself have traveled to Europe, to different parts of Europe, different parts of the world, but often Europe. And they will tell me that they can't eat bread in the United States, but they can eat pasta and bread in Italy, and different foods that they can't consume here. And all of that information really speaks to the level of where our industrialized farming and agriculture has gone in this country. Not everyone has access to farm fresh vegetables or can grow herbs in their garden. Some people do, and it's amazing if they can raise their own chickens, have their own eggs, but others really don't. For the most part of this country, a lot of people do not. So I think that there are many deficiencies that are even happening because of food. Our foods are just not nourishing us. And I think that's where, we've spoken about going back to the basic principles. We know we should eat more vegetables. We know we should, have enough servings of fruit. We go back to that, but we still could be deficient in things.
So two things, and then we'll to you, Dr. Ramsey. So two things I want to cover is one is that, I think that just like people want a pill to feel better, like a pharma pill, right?
Yes.
To feel better and to modify their moods. I think they want a dietary supplement that's, instead of taking, some people just want a dietary supplement, say, hey, you know what, if you take more of these 3 supplements, you'll have a higher likelihood to elevate your mood, and you should get it from food, but you may not. And I guess, for me, I think about this, often because I know that people want quick fixes. I've been advocating for healthy eating, for the last 25 years, 30 years. And it just, people aren't going to take that prescription of like, oh, well, I'm going to, eat food, and that's going to solve my depression. And that would be the ideal. I don't know if you know Judith Wertman from MIT, but she did a lot of work on serotonin, and her husband, Dick Wertman, did a lot of work on serotonin impact. She's a friend and amazing, and she's a chemist by background, sorry. And I once had a discussion with her about food versus dietary supplements, and she said there's absolutely no difference chemically. And I said no, but we don't know enough about the impact of food that it has, and the thousands of different things that are going on that nature brought together when we're taking that vitamin or that dietary micro and macronutrient, ingesting it as a whole as opposed to as a extracted supplement. And she said, I don't buy that. And she's an expert in this area. And so there is some of that argument, but I want to go back to what we were talking about.
What do you think she eats on date night?
She eats very healthy.
Hopefully dark chocolate.
She eats very healthy.
I think that one of the parts that happens is we start to extract these nutrients from food, and we make it sound like chopping vegetables, having a potluck, going to the farmer's market. I grew up on a farm, so part of what Uma's saying about, farming and kind of rural America, sort of resonates with me in terms of when you go there, it's fascinating that you're surrounded by places and people growing foods in garden, and it's the probably most processed food in one of the sickest parts of the country. And so, I don't know, I do think there's a way that we lose the food and the food culture and the part of nutritional psychiatry that I like the most, honestly, which isn't touting the research. It's actually helping people engage with the mentally healthiest part of food, right? Which is sharing it, growing it, nourishing yourself, rewarding yourself, appreciating the beauty of the flavors. It's like one of my major top gauges of how depressed I am is how engaged and how much I'm enjoying. If this kombucha doesn't really taste that good to me this morning, it's a little hint to me something's not going quite right with my mental health. If I'm not excited about a friend coming over and I'm making lentils, that's not me at my best. And so I don't mean to belabor the point, but I think there's a way that we get so obsessed with the nutrients and this idea that, we can just drink Soylent. It's like those tech bros don't seem happy to me. They don't seem like their life is rich and full. And I don't mean to sound so judgmental and that food's everything, but it's just like, I do think it's part of every culture for a reason.
Right. And I buy that, and I agree with that completely. But I guess I wonder, like, if someone's listening today and they're thinking to themselves, okay, this sounds great. I can't get an appointment with Dr. Drew Ramsey or Dr. Umanedu. So, and there are basically like 20 nutritional psychiatrists that I could probably put my finger on in the world. And I guess, it's like people want to know, what do I do? You two both wrote, these incredible books. And they're not just saying, hey, eat a Mediterranean diet. They're going through these macro and micronutrients. So I guess it's what is the, yes, and not everybody has someone that's going to sit there and analyze their diet and say, hey, you need more of this or you need less of that. And here's what you should be doing to improve your anxiety and improve your depression. So what do I do? I ask both of you, what do I do?
Do you want to go first?
I would say everybody who's listening, watching, hey, everybody out there.
3 minutes left, by the way.
Contrarian rant, so sorry about that. It's early in the morning in Wyoming. I'm feeling a little cowboy. But I would say everybody who's been listening to you knows a little bit about nutritional psychiatry because for you've been talking about seafood. And so for you, thinking about omega-3 fats, I'm kind of curious. You don't eat enough seafood. What's your favorite dish? I'd want to hear about your tinned fish game. So I think that part that Uma said, it being an individual, and for those of us who sit with patients, it's easy for us to say Mediterranean diet, but when you sit with somebody like, I don't like salmon, you can't say, good luck. Like, right? You say, oh, right. That's where you think about a supplement, or that's where you think about, hey, what happened with you in seafood? And what can we learn? Is there a way to, like, I didn't eat any seafood till I was 30. And so where I got help from nutritional psychiatry was learning about that, right? Taking that data, as Uma said, about omega-3 fats are important, and then realizing I want to get those from food. How do I do it? So I think the way you do it, though, is understanding everybody listening has a tremendous knowledge about what food helps them feel good and healthy. Everybody knows about plants and eating plants for the most part these days. Everybody knows about olive oil. So there are certain simple steps that no one should be confused about. They don't need a consult with me and Uma about some of the basics for mental health in terms of what foods to choose today at lunch.
Well, we do want them to buy your books, so.
Okay.
So yes, I would love that, and thank you if you're considering it. But actually, to answer your question, Charles, I do think that people need guidance. And to Drew's point, yes, I think that the conversation around mindfulness, having a community, having a tribe, like the Blue Zones Project looked at, these things really matter for our mental health. But when people just want an idea of how to do things, in my first book, what I did is I broke down the different mental health conditions, looked at the research. Charles, you know this because you've been through a similar thing. We had like 2,000 references, but we narrowed it down to about 553, breaking down the different conditions, including schizophrenia, bipolar disorder, OCD, PTSD, really went through everything in the broad categories to guide people in each condition. And there are lots of overlaps with the food, but there are nuances in every category. One nuance is that glutamates in natural foods actually drive symptoms of PTSD and OCD, and this has been shown. Another nuance is that, stevia, although it's a natural sweetener, can drive anxiety. So it might be okay to use in moderation in other places, but if you're anxious, it may not be your best choice. So I think there are ways that people can get guided by this. And, I do think, and I agree with Drew, people know what healthy food is. It's how do we encourage ourselves to make those choices and put together the plates. But that's a good way to start. How do you exclude something that you're worried about, that is not healthy, and how do you include more of those plants, the fiber-rich foods, and the healthy proteins, fats, etc.
So that went by very quickly, and I want to thank both of you. But I do want to ask, because we're almost out of time. We have about 30 seconds left. Where can people follow you, Dr. Uma? How do they get to you?
I'm on social media at DRUMANAIDOO. And you can check out my website, umanaidumd.com, where you can get my new book, my prior book, join my courses, and actually join my newsletter. I'd love to connect with people. And thanks for having us.
Sorry, Dr. Drew?
Same thing, except I'm Drew Ramsey, MD. DrewRamseyMD.com is my website. We've got some free downloads and some courses there. I'm on Instagram at Drew Ramsey, MD, and I have a Friday Feels newsletter and a Healing the Modern Brain e-course that everybody's welcome to check out. And thank you. It's just awesome to be with the both of you. And thank you for everybody who's listened. It's really it's fun to see this movement really getting momentum, and to speak with so many colleagues and providers. Just, ask your patients about food, see what happens. I think is probably when you ask what to do if you're a clinician. That's how Uma and I started, and it's just led to wonderful things.
Well, thank you both. And remember to go to nycfoodpolicy.org for the Hunter College New York City Food Policy newsletter. And the Center for Food is Medicine is foodmedcenter.org, where we do a news and research digest every week. And look at the latest articles and research that comes out every single week. You'd be shocked. Mary and Nessel was shocked at how much comes out each week. So thank you both, and it's been a pleasure. I hope one day we can actually sit and talk about this with at further length. And I appreciate both of you and all that you do. Your work is incredible, and maverick, and I think you both know that. So thanks everybody, and stay tuned. We have Dr. Robert Graham up next with Alexina Cather. And I think it'll be an exciting panel. Thank you.
Thanks so much.
For those of you just tuning in, welcome. Next up, we will hear from Dr. Robert Graham, a practitioner of internal as well as integrative medicine and chef and co-founder of FreshMed, in conversation with Alexina Cather from Wellness in the Schools to define food as medicine.
My name is Alexina Cather, and I am the Director of Policy and Special Projects at Wellness in the Schools, a national nonprofit that creates healthier environments for children to learn, live, and thrive. I am thrilled to be joined today by Dr. and Chef Robert Graham, co-founder of FreshMed, a Harvard-trained physician, board certified in both internal and integrative medicine with more than 20 years of clinical experience, who also happens to be an old friend. Thank you so much for being here today, Dr. Graham. How are you?
I am well. Thank you, Alex. And it's, whenever you call, I come running. So I'm happy to be sharing my thoughts on this very important topic with you today.
Thank you. I could spend the next 20 minutes talking about your bio, but just to keep folks engaged, let's start off by digging right in. Can we just start by you telling us what food as medicine means to you?
Yeah, so a couple things, because we're hearing this term, and I saw it on the actual flyer. You talk about food is medicine and food as medicine, and I just like to make a distinction, if I may.
Please.
The way I look at it is that food as medicine has been a movement around for 2,500 years. The father Hippocrates kind of coined it, let food be thy medicine and medicine be thy food. So that's the movement. Now, food as medicine, I look at as an intervention. So when we're using food as medicine, that's really what it means. We're using food as an intervention in healthcare, which, again, 2,500 years ago, the concept was brought up, the movement was brought up. But I think what we're looking at now, particularly in the last, say, 5 to 10 years, is really looking at food as a therapeutic in healthcare.
Okay. And you got involved in this, many years ago. And so how did you come to start being interested in using food in your practice?
Well, for me, it really goes back to how most traditional health systems value the role of food in health. So as some of you may know, I'm a product of a Latin American woman and an Anglo dad farmer. And so when you approach healthcare from what we can do in our own homes, the thing that we have control over is what we put in our mouths. And I was raised with the concept that, if you eat well, you will be well. And so in my culture, at my home and in my neighborhood, I realized quickly that if we want to be healthy, we need to put the right fuel in our bodies, and that starts with food.
100% agree. Just to dig in a little bit more, I've been seeing the food as medicine all over the place lately. I read an article just last week, I think it was in Produce Business UK, of all places, that talked about the overuse of these terms. So we're seeing them a lot in terms of products trying to use food as medicine, superfood, this detox will change your life, that what do you think about that? Do you see it as a problem, or is it kind of more an opportunity along the lines of any press around food as medicine is good press?
Well, yeah, I do think, good, any press is good press. But, let me go back a little bit. I'll promise I'll answer that question. But, when you look at food as medicine, right, it's integrating healthy food, real food, and nutrition education and programs into our current healthcare model, where we don't introduce food as medicine. It's really to help patients live healthy and longer lives. This can take many forms, and I'll talk about this a little later, but the things that I'm working on are things like medically tailored meals, medically tailored groceries, produce prescriptions, culinary nutrition education, culinary medicine. But in today's world, what we currently have in food as medicine, we have medical nutrition therapy, usually driven by registered dietitians, that is a form of reimbursable healthcare. And so I think words do matter, but I also think context is important. As I said before, this food is medicine, food as medicine thing has been going on for 2,500 years. Every single healthcare system, besides allopathic medicine, values the importance and highlights the importance of food. If you go to acupuncture or chiropractor, they'll ask you, what are you eating? And it's sad to think that 2,500 years later, we're still only now beginning to have that conversation. So yeah, I think context is important, but I also don't believe that we should be focused on so much of these nuances, really moving the field forward. And I think a lot of the work that has been done, particularly over the last, say, 12 months since the White House conference, is really kind of bringing and highlighting the importance of food into our healthcare delivery system.
Yeah, I'm glad you said that. I do think though that sometimes this term, and like you said, it's been going around for longer than you and I, much longer than anyone we know has been alive. But this term food as medicine is very buzzy, especially
True.
among the wellness community, which often can be very elitist, right? So food as medicine can be this thing that seems almost unattainable to the average person, and they're not thinking, oh, I can just get that from going from a checkup.
Right.
So how do we change that so that it's not this wellness thing that you have to, be able to buy that latest elixir or that latest, green drink, that kind of thing, that's food as medicine, but it really
Yeah.
should be more than that. So how do we change that framework and that mindset?
Yeah, so I think you bring up a very important point because oftentimes in the space of, let's say, holistic health, integrative health, functional health, everything that you're hearing in terms of PR and marketing in this space, is and can be really tied to wealth. And health should be outside of wealth, right? Is that we should have the opportunity to live this wonderful life equitably. And what I'm talking about here is really nothing a quick fix, no fad diets, no supplements, no functional foods, no superfoods, right? Because intentionally what we eat should be fueling us. And the facts are this, right? 63% of Americans 63% of our calories come from processed foods, right? What I'm talking about is real food, making it accessible and equitable for all. And in fact, the biggest killer, and I think oftentimes people ask me, what is the worst food out there? I think ultra processed foods are our enemy, right? And part of the problem we have in our society today is that, news is important. And the idea here is that every couple of years, and I bet the audience here can attest to this, there's always one bad guy in the field. Gluten's bad, butter's bad, sugar's bad, this is bad, gluten is bad. There's always a bad character, right? And fat is bad.
Red
And
meat. Yeah.
red meat is bad, right? And I think what at least I'm trying to do, is bring back the conversation about eating real food. Michael Pollan said it best: eat real food, mostly plants, not too much.
Yeah.
Those are the 7 most important words in this good food movement. And I think if we start going back to what our ancestors, our grandmothers and mothers fed us, right, we wouldn't be in the problem we are today. And in fact, it's the processed foods, the ultra processed foods. And I just want to say that for every 10% increase in ultra processed foods we consume, we have a 14% increased risk of death. So I'm not taking anything away from people, but in fact, I think, processed foods are labeled as WHO labels them a class 1 carcinogen. And I was very proud of the work we did years ago with Mayor Adams, on banning processed foods in our school systems, and I think hashtag ban the baloney. I think that's really important. And I think we have to go back to the fact that our food is literally killing us, right? It's a leading cause of death and disability. And I think if we return back to what we consider real food, I think that's what I'm focusing on, right? I'm not focusing on any sort of superfoods. I think the most important superfood out there is beans and greens, and I would argue no one would tell me that's really that bad to be consuming most of those.
So if Michael Pollan has his mantra, yours is beans and greens.
Eat more plants.
Eat more plants. Okay. All right. So that's kind of what I'm hearing you say at home, which of course I agree, and I think most of the people on this call would as well. But when we're looking at the doctor's office and expanding and increasing access to food as medicine from that capacity, are doctors even the right person to ask for food as medicine? Or if it's a true prescription, should it be a pharmacist or should it be a nutritionist, an RD? Like, how do we really level up so that we're reaching the maximum amount of people, knowing that I go to a doctor's office and I might have my doctor for 5 minutes if I'm lucky. And that the doctor might have received 1 day of nutrition education in med school. Like who is really the best person to level the food as medicine interventions up and make it more accessible and equitable?
Well, one thing, and I've been traveling a lot lately on this topic, and everyone has a role. And everyone you mentioned has a role. I think our chefs have a role as well. And years ago we did this amazing conference. It was called Everyone's Invited to the Table, and I think that's a really good mantra to think about, right? That everyone has a role in improving our food systems and our healthcare systems. And so everyone you mentioned should have a role. And you're right. Doctors just have a paucity or a lack of nutritional education. And so maybe they're not the best person. But you know who we have in our clinics and we should be referring more to? Registered dietitians. Registered dietitians are the experts on food and nutrition. And sadly, most of the chronic diseases can be either prevented, managed, or treated with a food first approach. And that's the reason why we started our practice, Fresh Medicine, right? We have a food first approach. And so therefore, if I can't talk to my patients about a chronic disease that's impacted as a food related illness, refer to a registered dietitian. And if it's called a prescription, maybe pharmacists have an important role in terms of healthcare delivery. Mind you, you may go see your doctor once a year, right? If you're on a medication, you probably see your pharmacist, every month or if not quarterly. So I was just down in DC talking about what is the role of the pharmacist in the food RX movement. So I personally believe everyone has a role, but I also want to mention one thing. Doctors have an important role because for the physician out there, every single disease process we have out there, okay, has a therapeutic lifestyle intervention that should be explored and optimized within the first weeks of diagnosing. Hypertension, diabetes, every treatment algorithm out there, but every college says optimize and utilize 6-week therapeutic lifestyle changes first. And if that doesn't happen or succeed, then you go into pharmaceutical management. But that's not what we do, right? And part of it is that we're a volume-based system. You're in and out of there in 15 minutes. And that's simply not good for patient care. It's not good for doctor well-being and burnout, right? And so it's a lose-lose for everyone.
Yeah, I'm glad to hear you say that. So everyone needs to be involved, no siloing, all hands on deck, and that certainly makes sense given the gravity of the issues with diet-related diseases in this country. You said you were just traveling. I know you were at the American College of Lifestyle Medicine and Millikan Institute talking about food as medicine and more broadly about food as health. Can you share a little bit with us about what you spoke about, what you learned, like what are the practicalities and the scalability of it all?
Yeah, so we are in a healthcare crisis, and there's nothing new, right? We've heard it, and the lifestyle medicine really kind of reemphasized what I just mentioned, that there is a lifestyle prescription that is recommended by all societies in terms of managing diseases like hypertension, diabetes, and obesity. We just don't do it, right? So I'm not offering something new. I'm just returning back to evidence-based treatment algorithms. Okay, so that was lifestyle medicine, and what's fascinating is that now we're starting to get reimbursement for lifestyle counseling. We're getting increased reimbursement for registered dietitians. We're getting increased reimbursements. Hopefully by next year, CMS will be covering health coaches as part of our treatment team. What was fascinating about Milken, it was, I spoke on the food as medicine sector, but the concept of the whole conference was the future of health 2.0. And what made me feel really energized and inspired by it is that, the old Wayne Gretzky quote, how do you know, why was he so great? Because he knew where the puck was going. And that's where the puck is going, right? We just can't sustain the way we do it today. And so we have to develop a new model of healthcare, which I believe that if the food is the number one cause of our problems, it is the number one solution in our toolbox. And we just need to kind of leverage the power of the people for demanding more from our healthcare systems, because I think people are doing it. We just have to start learning how to integrate this into a healthcare system, which unfortunately in our society is insurance-based, mostly commercial-based, and insurances and business have to take ownership. And so that was a really interesting meeting, particularly at Milken. It was that every single sector, from the average patient to the business that supports their health insurance, has a vital role in changing how we deliver healthcare by putting food first.
Yeah, so that I like that it's disheartening, definitely, how the issues, but food can also be the solution, right? So can you give me a real, like a case scenario? So a doctor, you're a doctor and you're in your office and a patient walks into your office. How do you operationalize a food as medicine intervention when this patient walks in?
All right, so the biggest problem we have in our society is these chronic diseases, right? 9 out of $10 are spent on chronic diseases, and there's no magic one pill for that problem. right? It's really looking at a holistic approach, right? And it's bankrupting us. It is bankrupting our healthcare system. And so the way we approach it, I'm going to use my example. And one of the things I'm really excited about is to tell you later a little bit about my new role with a large healthcare system here in New York, is that we believe that we have to treat patients, again, going back to the treatment algorithm. There is a diet, the DASH diet. Let's say a patient comes in, 60-year-old guy with hypertension and diabetes, okay? The first question is, how do we manage them? And so before jumping into our medication, ultimately, they're usually on a medication. We talk to them about the diet, the DASH diet, and how to implement that into their sort of everyday life. And it's been evidence-based. The diabetes prevention trial, also, diabetes prevention trial is a lifestyle, food-focused approach to prevent and halt and regress diabetes. So that's the first conversation, right? The role of food in whatever we're dealing with. The second thing, what I'm really passionate about, is using what we are discovering with the company I work with, medically tailored meals. So the person that comes in with diabetes or hypertension, here, eat this, right? We eat this for 3 weeks. We get some sort of control of what's going on while we refer them to a registered dietitian and then transition them to a produce prescription. The analogy I give is something like this. You break your leg, you got to get a cast and a crutch. That's your medically tailored meal. Then what you need is to go to rehab. Rehab is a registered dietitian, but you're not going to be on the medically tailored meal, God bless you, medically tailored meal for the rest of your life. So you transition to produce prescriptions. That's where the role of nutrition education, culinary medicine really is important, because ultimately what we haven't been able to do is get people back into the kitchen and cook for themselves, take ownership of their own health.
I love that. That really helps put it into perspective how it works. So, so after that, how do we get this? Do we do it in the office? But then how do we make it part of reimbursement, electronic medical records, all that? And then finally, I know you'll be able to add to, how do we get meals to people?
All right. So let me start with that last point. So one of the things that we do today, that this is a fact, okay? Most people who are on Medicare have a supplemental plan called a Medicare Advantage. Medicare Advantage programs, right, have certain benefits. Most of them have a food as medicine benefit, either the form of produce prescriptions and or medically tailored meals. The problem is that patients don't know about it. The problem is that doctors don't know about it. So what we've taken at Performance Kitchen, okay, is that if you go to our website, we identify what insurance plans currently cover medically tailored meals in your zip code. So you go to the website, you go to our benefit locator tool, you plug in your name and your zip code, you can identify the insurance companies that offer medically tailored meals benefits today. Now we have to put pressure on the insurance companies to execute on the existing benefit that they promised their patients. So that's the next step. But the other thing that's really exciting now is that we have a lot of demonstration projects to identify the best practices on how to deliver this. This is where Medicaid, 1115 waivers are coming through the country, and I know the panelists later are going to be talking about policy, but demand more. This is to the patients out there. Demand more from your healthcare system and your insurance companies. Be an advocate, because again, it's the gym membership model. The gym membership model really is about enrollment and not engagement. So engage with them. Find out what is owed to you, because you pay a lot of money for these benefits and they are owed to you today.
Thank you. So it's being underutilized, right? And then the more that there's demand, possibly see other opportunities. So that's really helpful. So we have 1 minute left. I just want to ask a quick, since we have you here, probably everybody wants to know what does a doctor order? What are the doctor's thoughts on the following? So superfoods, real quick, couple words.
Beans and greens.
Beans and greens. All right. No magic superfood. Meat.
Make sure it's good meat.
Alcohol.
Never initiate. Keep it to a minimum.
Supplements.
Supplement a deficiency in your diet.
Perfect. Sleep.
One of my 5 pillars.
Can you say the other ones real quick, just in case people don't know?
So fresh started from an acronym called food, relaxation, exercise, sleep, and happiness. Those are 5 ingredients in a recipe to health. We have an online school too, FreshMedU. If you want to go check it out, it's free. We have a free course. Learn the basics about those 5 important pillars.
Fantastic. And finally, what is your, as we head into the winter, Favorite cure for the cold?
Rest.
Rest. All right. You heard it right there, everyone. Dr. Graham, thank you so much for being here today. It's always great to see you and spend time with you. Take care.
Always my pleasure. Thank you.
Welcome back. For those of you just tuning in, our next panel will explore food and cancer, separating fact from fiction.
I want to welcome you back, and I want to thank Alexina Cather and Dr. Robert Graham. What a wonderful discussion. What a wonderful, incredible job. And I want to welcome you here today to our next discussion, which is about cancer and how food and dietary supplements impact cancer. And Dr. DeAndre, Dr. Eingar, and Dr. Shaw, thank you for being here today. Really appreciate it. I want to start with this term, the war on cancer. What is that? And, what should we know? And, it's been used for decades to describe this complex disease. Could you provide some context for us? Dr. Eingar?
Sure. Yeah, happy to kick it off. So, I think this refers more broadly to all of the multiple efforts that are going in, both clinically and research-wise, to improve outcomes after a cancer diagnosis, and also to detect cancer diagnoses earlier in an effort to not only improve outcomes, but also potentially to reduce risk by recognizing what key risk factors exist and how we can intervene before the cancer actually develops. So there have been many advances in most cancers. I'm a breast medical oncologist, and so we've seen a lot of recent new drugs, new types of drugs that have been approved by the FDA, new types of hormone therapies for breast cancer, prostate cancer, and even other types of cancers, new types of molecular therapies, and even new types of chemotherapies for breast, lung, and prostate cancer. Immunotherapies are also in development or being used for the treatment of these cancers and have measurably improved survival after a cancer diagnosis. But we still have a lot of work to do, and there's a lot of research going on to develop even newer therapies or to improve the side effects and efficacy of our current therapies. The last thing I'll add is that a lot of our newer therapies we're now learning actually have metabolic effects and can alter the way that our insulin signaling and other types of hormonal signaling works. And this has really highlighted the impact that lifestyle interventions like diet and exercise and metabolic medications can have on both the tolerability and even the effectiveness of some of these newer cancer therapies.
And just before we get into that, so because again, I was telling you before in the green room, the virtual green room, that I have a colleague who is a health literacy expert around the world, and she's sort of her whole process and programming is about how physicians and we translate these messages. So what does that mean, metabolic? Well, what are we talking about when we say that?
Yeah, this is, a term that we've started using more and more, metabolic health. And I think that what that largely refers to are things like your energy balance. So for example, how much, calories or energy are you taking in and how much are you expending? A classical state of energy imbalance is obesity. And we used to talk about obesity-related cancers. But now we are discovering that yes, obesity is a major risk factor for the development of cancer, but there are other metabolic factors. So that could be things that we typically think of as associated with diabetes, like the hormone insulin, which is responsible for sugar control in your body, like other hormones that are secreted by fat cells. And this really generates a state of your overall metabolic health, which is essentially how efficient is your body at storing and expending energy, and what are the things that you do in your lifestyle that heavily influence this delicate balance.
Dr. DeAndre?
Yeah, I agree with all of that. And I think, with regards to the war on cancer, and we've certainly made a lot of progress in the last 20 years. But, some of the therapies, such as immunotherapy, it doesn't work for everyone. And also some of the cancers, such as pancreatic cancer, brain tumors, for example, we haven't really figured out how to use immunotherapy in certain subsets. And what's very interesting is that diet and the microbiome, so your gut bacteria, may play a big role in this. And so again, this is another area where lifestyle medicine and nutrition become very important for our patients on immunotherapy.
And Dr. Shaw, can you talk about, first of all, how many types of cancers are there, and can we really generalize like this, Dr. Shaw?
So overall, meaning it's hard to count the number because as many organs and tissues we have, most of them can at some point be at risk to develop cancer. But I think, some statistics say that 1 in 2 people in their lifetime will develop cancer, or the risk of cancer, it's a little higher in men compared to women. So I think this is something that affects all of us, either directly or indirectly somehow. And I think with treatments and the newer therapies, as you already heard from Dr. Iyengar and Dr. DeAndre, we've moved through many phases of different kinds of therapy. It was first the cytotoxic chemotherapy, then targeted therapies, and now we've come to the next frontier, which is kind of immune therapies. But all of these therapies don't work for all diseases, and they're very specific ones. So one of the cancers I treat is multiple myeloma, and we've made considerable progress in this cancer, which even when I was in medical school, the survival was about a few years on average, and now it's over 10 years, the median survival. And this is just with the advent of all the newer immune therapies that we use, like bispecific antibodies, CAR T-cell therapies, and other things. So there's lots happening, and it's moving at a very rapid pace. As oncologists, we have to constantly keep up. Even just keeping up with one disease is a lot, as most oncologists will tell you. And just sorry to add is that I think that the next frontier, and why nutrition is now also becoming more important in oncology, is the understanding that the microbiome plays a big role in cancer and things, and how diet is one of the biggest drivers of the microbiome. So now we're also seeing microbiome-directed therapeutics that are affecting outcomes in cancer. And there was one recently published in metastatic renal cell carcinoma with checkpoint inhibitors. This was a supplement which was a live bacterial supplement, and showed that actually that might improve survival for these patients. So I think, again, we're seeing, a shift towards understanding, and I think the microbiome therapeutics are the next frontier, probably.
And given that, I this is something that we talked about before, is that considering cancer encompasses over 100 different diseases, each with a unique pathology. And in response to treatment, how do you approach this complex task of advising patients on dietary nutrition choices? And the NIH's National Cancer Institute highlights that no single food or special diet has been proven to control cancer universally. So, and we just kind of talked about this, but the relationship with diet and cancer is complex and evolving. Can each of you discuss specific dietary factors such as nutrients, food groups, and dietary patterns, and that have been found to impact cancer, not cancer risk mostly, but the progression and patient outcomes? If you're, think of this as we're at a cocktail party and someone says, "Oh, what do you do?" And you say, "Oh, I'm an oncologist, cancer expert, and actually in an integrative approach, I have an integrative approach." They go, "Well, what does that mean, an integrative approach?" And you say, "Well, what?" What do you say?
So
Stacey, we'll start with you.
Oh yeah, go ahead.
Oh, sorry,
Sure.
Stacey. Yeah.
Yeah, sure. So, so integrative medicine, I look at as using lifestyle factors. So lifestyle factors are kind of the pillars. So where we really work on nutrition, we work on stress reduction, improving sleep, getting people moving and exercising. So encompassing all of these very, very important pillars of health. And then adding in supplements when necessary, correcting deficiencies in, vitamins. We do blood testing. Some integrative docs will do gut microbiome testing and go, a little bit deeper. We also will use other techniques to help with symptom management, such as acupuncture, acupressure, just to help with symptom control. So I feel like the lifestyle piece is so fundamental, and I spend a lot of time working on diet and exercise and these basics with many patients. And then, the other stuff is kind of supplemental.
So, but not supplemental, not supplements, dietary supplements.
No, like an add, in addition. Right. So once we have the basics down, then we can start diving into some other things. And, of course, every patient is different in terms of what their needs are. Are they finished with therapy? Are they on therapy? I mean, things are very different. If you're on chemotherapy, immunotherapy, a lot of times we don't use a lot of supplements because there can be interactions that we want to avoid. So you really have to look at where your patient is at, what are the goals of the therapy, and kind of tailor a plan for that individual patient.
So jumping into this and just adding to it, and then having each one of you go further with it is, okay, so you're diagnosed with cancer, and let's say it's breast cancer, and Dr. Iyengar. So what happens next? And I would say to you, well, I'd like to I want to eat a little bit better, but I also want to take some dietary supplements. What should I do? I went on TikTok. I saw that turmeric is going to help me and maybe even cure my cancer. What do you say to that to a patient?
Yeah, it's a great question because it's just such a fire hose of information out there, and discerning what is accurate and real versus what's not versus what's still under investigation can be a real challenge for many people, including physicians and medical professionals. And so, when somebody's just been diagnosed with cancer, let's say breast cancer in the example that you posed, this is an overwhelming diagnosis. And there's a lot of information that a person has to take in. They're meeting with multiple doctors, multiple healthcare professionals. They're getting a cancer treatment plan, which oftentimes includes chemotherapy, surgery, radiation, hormone therapies, a variety of different treatment modalities. And I would say that we generally do a fairly good job in terms of creating that kind of tumor-directed plan. This is what we're going to do to treat your cancer. But where there's a lot of variability in terms of the treatment plans are what you should do with your lifestyle. And I think a lot of folks will then turn to the internet, to social media, because they're not oftentimes getting that information from their medical teams. And that's what investigators and clinicians like us on the panel here are hoping to improve, that we can, through research, through advocacy, through panels like this, we can get that information out there and direct folks to appropriate sources. So I would say, the first thing to do when you've been diagnosed with the cancer and you're given your treatment plan is, of course, to ask your oncologist or your oncology team, what can I be doing in addition to this treatment plan? What kind of lifestyle interventions or alterations should I be looking at to incorporate at this point in my journey and this early point at diagnosis? And oftentimes that will lead to a referral to an integrative oncologist like Dr. DeAndre. It'll lead to a referral to a nutritionist, an exercise physiologist, or a physical therapy group. There are clinicians that are out there that can help you individualize the recommendations that are specific to your type of cancer and your type of cancer treatment. That being said, there are also some general principles that we can rely on to guide you and at least give you a start while you're waiting for perhaps a more individualized approach. We've seen, for example, in multiple studies that it's really your overall dietary pattern that matters the most. And Charles, I think you had alluded to the fact that NCI and other groups have suggested or have strongly indicated that there's no single food that is protective against cancer recurrence or the risk of cancer. And that gets to this point that I just made, that it's really your overall dietary pattern. We've observed in many studies now that a minimally processed, plant-forward diet seems to be associated with the best outcomes after a cancer diagnosis. There may be some niche areas where other types of diets may be helpful, but that's where the research is ongoing. So that's why I generally say, let's start with these kind of overarching principles that have generated the most amount of data: plant forward, high fiber, minimally processed, minimize alcohol. Once we start with those kinds of principles, which for a lot of people is a major shift already, once we establish that, then we can get more specific.
And it's interesting you say that, and then we'll go to Dr. Shah, but it's interesting you say that, and you didn't say, thank goodness, the term healthy diet, because that means almost nothing. I taught graduate nutrition and undergraduate nutrition, and you ask that group, okay, what's a healthy diet? Well, what's a balanced diet? It's almost meaningless. So, so the fact that the specificity is really important there. Dr. Shah, you had some things to say. I think we cut you off by accident.
I think they've covered it really well. So we can, I think, move to the next question if you'd like. So great answers.
Thank you. Thank you. So now, looking at moving further, on this, how do you balance the enthusiasm, for natural and dietary interventions with the need for rigorous scientific validation? So, you get patients that come in and say, hey, I heard that this particular dietary supplement really will improve my well-being and help with anxiety and also reduce the spread of my cancer, and they may or may not be proven. They may be from Eastern medicine or what have you. And all three of you consider yourself integrative in terms of your practice. So what do you tell a patient that gives you that, and how knowledgeable are you on all the latest research on dietary supplements and impact on different types of cancer? So there's a lot of questions there. We'll start with you, Dr. Shah.
So it's a difficult question because I don't think we have answers to all of it, unfortunately. And the reason is because supplement research is not similar to the way drug research is done. And a lot of supplements, if we try to do the research for every supplement to the level that we do with drugs, it would be great. But the number of new supplements that keep coming and the new versions, even like curcumin, there's curcumin C3 complex, curcumin with biopurine, and now newer curcuminoids. So it's hard to really fully study each of them to the level that we do study drugs. What we can say is that, okay, what do we know a little bit about, or what is the data from maybe preclinical studies or animal models, or even in small studies that have been done by sites. But having randomized phase 3 studies often with these supplements is a rare thing that we will see. And we've seen a few like that with vitamin D, for instance, and cancer, but really not things with most of the other supplements. And so we have to go a little more with anecdotal data. So it's a bit hard to recommend it across the board to all patients. And I think it needs to be individualized and thought about in terms of the context of their symptoms.
I think that's really important points that Dr. Shah brings up. I think that what I typically do in my practice, and I think we heard both Dr. Shah and Dr. Deandra suggest this or state this. I start off when somebody's starting cancer treatment. I start off with a baseline of let's level set and let's look at everything you're taking. And the first priority is to minimize interactions. And because of that lack of study, of extensive study of supplements, as Dr. Shah was saying, we oftentimes don't even know what the potential interactions could be between a supplement and cancer therapy. And so my default is really to start off with, let's try for no supplementation, see if we can achieve a lot of the nutrient intake from your diet. Because oftentimes a lot of the synergy in these nutrients is lost when you isolate it. Turmeric is a great example. I prefer that folks consume turmeric through the turmeric root or the powder rather than the pill or the supplement. But there are situations where supplementation is necessary if somebody has a deficiency, as Dr. Deandre referred to earlier. Or if we have that phase 3 data that Dr. Shah was talking about, which suggests a supplement is helpful in a specific circumstance. So it's good, again, to start off with that sort of general principle of let's try to get all of your nutrients from a whole food-based approach. And then in certain scenarios where there are deficiencies, where there is established data, then we can start to individualize supplement recommendations.
And Dr. Deandre, question for you. What we all were just sort of talking about, how are other oncologists and cancer experts considering this integrative approach? And is it like, when you're with your colleagues, is it like, oh, they're thinking integrated, like, that's great, that's like 5 years, like 10 years away. Thanks, guys. But I mean, obviously they're not doing that, but the body language maybe. How is it seen amongst all your colleagues with no patients there? What's the inside story?
Right. So I think, things have changed in the last 5 to 10 years. I think, practicing integrative oncology is a relatively new field. And I started at Mayo Clinic, this new practice here 2 years ago. And we are booked out for months, and our team continues to grow. And so there's a huge demand. And I think the oncologists are very supportive because they see the patients coming back to their own practice and they're doing better, they're feeling better. So it's kind of like the proof is in the pudding of what we're doing. And we do lectures all the time. So we're constantly doing educational lectures for the staff, for the nurses, for the physicians. And so the more you can put stuff out there and show there is evidence behind a lot of these things. The Society for Integrative Oncology has recently published a whole bunch of guidelines to help treat anxiety, depression, pain. So there are guidelines that are actually adopted by ASCO, which is the oncologist governing body. So the more we publish, the more science we do, and the more we get these things out there, of course, the more our colleagues are going to be, more ready to accept these things. But, I'm embedded in an oncology clinic. So I'm working with the docs and the nurse practitioners and the nurses side by side. And so that is, for me, been a great model because they see what we do. We're seeing the same patients, we're sharing experiences, and it's been great here. Great adjunct, I think.
And what are the, like, and again, I hate to do it like this, but like if I'm your best friend, Stacy, I'm calling you Stacy, not Dr. Deandre, and I say, Stacy, what should I take? Should I take a supplement? What should I take? Turmeric, on a for prevention, or I have cancer in the history of my family. What dietary supplements? And yeah, I know I should be planning forward, but I'm not doing that, because I just can't. And what should I do, Stacy? Tell me. So
generally, I don't recommend supplements to treat cancer. So in terms of actually treating malignancy, there's just really a lack of data to support using supplements in that fashion. And then you start getting into more alternative medicine where people are on these protocols of lots and lots of different supplements that, there may be mouse models, there may be preclinical models that they're supposed to do something, but it's very hard to really, to recommend those types of things. So I think, as an individual patient, we do check certainly vitamin levels when necessary. So many patients do have vitamin D deficiency, and we will sometimes recommend either food supplementation or dietary supplementation to correct that deficiency. But when you're getting into other things, we really push a food forward, using the spices in your diet, getting the stuff from your diet for the most part. Right. I think there's more to come with regards to the medicinal mushrooms. Many of my patients will be taking some of those, and there is some data. There are meta-analyses and data out of Asia supporting the use of some of these medicinal mushrooms. We certainly need to replicate some of the studies with turkey tail and reishi mushroom, but they are immune stimulants, and those may be useful for some patients. But again, you really need to look at what is the patient on, what are the goals. I can't say across the board there's any specific supplements I'd recommend for everyone.
And then, you mentioned something, and so did all three of you mentioned this, about research, right? And research isn't supporting it. But one of the things, at the Center for Food as Medicine and the Hunter College New York City Food Policy Center, which I used to be the director of, we did a joint research project, one of the first academic of its kind, which you can find on both of our websites, this 300-page with thousands of citations report on food as medicine. And one of the recommendations was that there's not enough, governmental research support on dietary supplements, on how food impacts cancer and different types of cancer. And I don't know if you guys are applying for grants in these areas, but it's kind of a little weak. So when we go to the research to try to see, and I just spent 5.5 months looking at anxiety and how food and dietary supplements impact anxiety. And I noticed that, I found some really great studies and great systematic reviews and so forth. But really, there's not a lot of great research out there because I don't think there's a lot of funding for that. And it's very hard to apply for grants for that. So I feel like that's a big problem. So can you address that? And we'll start with you, Dr. Shaw, if you will.
Sure. So we're trying to address some of these questions. For example, in plasma cell disorders or multiple myeloma, there are a lot of patients who have the precursor state, like before cancer develops, called smoldering myeloma or MGUS, or monoclonal gammopathy of unknown significance. And these patients are told that they have a higher risk to develop cancer, but there's nothing to do other than observation. There have been some small trials showing maybe that curcumin could maybe have some potential benefits, and then some preclinical data on like omega-3 and things. So many patients just hear that little bit of information and then start taking these supplements, but they're expensive. And we don't really know, is this really helping them? So we are actually doing a study that's currently enrolling, where we are looking at these patients with MGUS and smoldering myeloma and randomizing them to get a diet, which is a high fiber, whole food, plant-based kind of diet, or supplements, and they get the curcumin and algae omega-3, or they get placebo supplements. And this is a 150 patient study that's enrolling since December, and hopefully, we'll finish enrollment next year. And similarly, we're going to do a shorter study with another foundation as a telehealth, which will start next month, where we're looking at different supplements just in a small group of patients to see the effects on the microbiome. And with our studies, because we're going to be collecting samples like microbiome and understanding the immune system, we can really look into these supplement effects more in depth than just the clinical outcomes, because sometimes, just understanding really what are they doing to the physiology and things like that is going to be helpful. And simultaneously, we're also running a survey for patients, with plasma cell disorders to understand what supplements they take, what benefits they see, and is this really how much they spend per month and things like that. So hopefully we'll have more of that next year to share.
And are these government funded studies?
Currently, there are patient foundations that have funded these, but I think, the next step would be like once we get this data to maybe write a study that would be funded by apply to the NCI or NIH for the next level of funding. But
Yeah.
I think we'll get the prelim data from something like this.
So Dr. DeAndre and Dr. Eingard, so what do you think about this, lack of funding? Am I missing this, or is that changing, or what's the face of that in your opinion? And are you applying for government grants to support some of these integrated programs, and whether dietary supplements or food-based treatments, coexisting with pharmaceutical treatments and chemo and immunotherapy? How is that? What's the story with that?
So, I think that the government, there's funding out there, but it is difficult and it is very competitive. Much of our funding for our research does come from philanthropy, and also just, small internal grants to do pilot studies. So often we will get, a small pilot funding internally or through a local cooperative group to try to run a pilot. And then if there's some evidence for efficacy in the pilot, we can go to a bigger cooperative group or then apply for more government funding. You have to have preliminary data. If you don't have preliminary data, you're not going to get a big government grant. There was just a big grant that came out for cannabis research, and it was extremely competitive. We applied, we didn't get it. So, we keep trying, but it is challenging, and there aren't as many opportunities as I would like to see. Again, most of our funding for many of our supplement we've got a number of trials using mushrooms. We just completed a cannabis topical trial. All of those were funded through philanthropy.
And I can add to, I think that, I'll add and say what I think folks are hearing is that there is obviously a need for this type of research, and it's really advocacy and those patient-centered groups that are initiating a lot of this support for this research. So what we try to do is really cobble together what the type of fundings that we can get. So, our research portfolio is supported by grants from the National Cancer Institute, where we are looking at structured exercise prescriptions in the setting of metastatic breast cancer to try to test the most biologically effective dose of aerobic exercise. We've just completed a trial that was supported by the American Cancer Society, testing a plant-based diet with structured exercise in women on hormone therapy for the treatment of breast cancer. And we've got several other trials that are testing various types of dietary and lifestyle interventions funded by either small philanthropic groups, patient advocacy groups, and a few government grants. I will say industry, the pharmaceutical industry, I think is now also starting to pay attention as we generate that data. So for example, we have a trial that's testing a ketogenic diet versus a low-carb diet versus a diabetes medication for patients with a very specific type of breast cancer. I don't generally recommend a ketogenic diet, but there are very specific areas where it may be helpful. And that is a study that is funded by Novartis. And so I think there are areas where as we generate more data, as Dr. DeAndre said, we can actually start to get the interest of not just government funding, but industry funding as well.
Right, and so it looks promising, but still, we're years away from getting the kind of research where you're going to sit there and tell a patient, hey, here's a dietary supplement. The research is fantastic. There have been several government funded studies and this is what it is. Or we're seeing more of that. I think, these kind of better studies around food diets, because I think it comes out of more prospective studies and tracking that's done less focused on the specific diet, but showing different outcomes that are based on and positive outcomes, let's say on Plant Forward or Mediterranean diet, that are showing better outcomes overall, meaning less cancer, and then extrapolating some of that to make a decision that maybe you should be doing this if you're diagnosed with cancer. Am I getting that right?
I think so.
Head shaking, yes.
I think the other issue is when we do launch these studies, getting patients on the studies is incredibly important, and to do that quickly. You know, there was a study, you mentioned the Mediterranean diet, so the Diana-5 study, which was a breast cancer study testing Mediterranean diet, was just published earlier this week, but it took nearly 10 years to accrue to that study, and a lot changes. The type of cancer treatment we use for breast cancer changes over the course of the 10 years. And that can make it challenging to interpret the results of studies. That study was reported as a negative study, that a Mediterranean diet perhaps didn't affect outcomes after a breast cancer diagnosis. But if you look at the folks who actually adhered to the diet, their outcomes were indeed better. So I think that we face a lot of challenges. Funding is the big challenge. But once we open these trials, it's also, you know, a challenge, but important that we get the word out there so that people know where to look for these trials and can join the research.
Okay. And getting the right patient population, you know, to join the studies as well. So, you know, dietary studies are not always easy to do, especially when you're getting into more restrictive diets like ketogenic diet. I mean, there's a lot of dropout. So patients, you know, they think it's going to be okay. They sign up on the trial, and then they, you know, half of them drop out. So that's a big problem when it comes to testing different types of diets. The other type of diet is fasting, you know, in terms of doing some sort of either intermittent fasting or sort of a fasting mimicking or low calorie diet before chemotherapy to decrease side effects. Again, has to be the right patient. There can be issues with weight loss. A lot of patients drop out of those type of studies, so making some of the results a little difficult to interpret and also to generalize to, you know, the general community. If half of your patients are dropping out of studies, you know, and they're the motivated patients, it's hard to think, how is that going to be applicable to everyone else? So those are just some of the challenges that we've encountered.
Interesting. And then in terms of supplements mitigating chemotherapy and radiation, because this is very specific and a little different than treatment, even though it probably is aligned with treatment. And what is the, I guess, the current understanding? That I guess there's things like, you know, ashwagandha, CBD. We discussed some of this, N-acetylcysteine in reducing chemotherapy and radiation side effects. So are there trials? What are the trials been showing around that? Dr. Shaw, are you aware of sort of?
I'm not aware of any big trials that have shown any significant data for these, and so I do not discuss or recommend these at this time, but maybe Dr. DeAndre knows more about the integrative side around these specific supplements.
Yeah, I mean, in terms of cannabis, you know, there have been lots and lots of studies in terms of using either CBD, THC, the combination as symptom management. Yeah. So there is data for, you know, at least some preliminary data that cannabis may help with nausea, it can help with pain, and anorexia to some degree. CBD alone really doesn't do a whole lot for patients with cancer, so we generally do not recommend CBD by itself. With regards to the other ones, I mean, yeah, there's some data with regards to helping with stress with ashwagandha, but it has interactions, so it's not something that I use, you know, a whole bunch of. We do use quite a bit of Wisconsin ginseng. We're actually mounting a final confirmatory study using Wisconsin ginseng for fatigue. We've run 2 clinical trials that showed that did help with chemotherapy-induced fatigue or cancer-related fatigue. So that's an interesting supplement. I think we'll see, you know, more results coming out with that shortly.
And then we have about six minutes or so left, or 4 or 5 minutes left. I did want to ask about inflammation and the impact on cancer treatment, and really discussing. You know, inflammation seems to be a big problem, right? And again, I'm not an expert here, but you know, we know that alcohol, that there are many factors in this. You know, certainly diet. Have you heard anything about anti-inflammatory diets and the impact of cancer and its progression. And then also, before we finish up, I do want to ask about sugar and specifically alcohol. And sugar, and I know this is a three-part question, but sugar in terms of, there are milkshake programs in cancer hospitals because people are not eating, but we've been told that sugar it causes cancer cells to grow. Maybe a myth, I'm not sure. And alcohol, certainly, everybody has different alcohol levels of what they drink, whether it be, a bottle of wine a day, and if you're diagnosed with cancer and you're drinking a bottle of wine a day, should you stop doing that? So these are three questions that I want to finish up with. So anti-inflammatory diets, sugar, and alcohol. Anybody can jump in.
Sure, I'm happy to kind of jump in there, and I'll bundle the alcohol and the inflammation question together. So, we've actually, our research program embarked on the lifestyle intervention studies by first making the observation that fat tissue can become inflamed. And that typically happens in the setting of energy imbalance, where if we start to put on more fat tissue than our bodies can handle, the fat tissue can no longer do its job of acting as the broker of energy stores. And instead, it becomes dysfunctional, inflamed, and starts to produce growth factors that can promote tumor growth. And so there are many different types of inflammation. That's just one of them. There's systemic inflammation, where there are molecules that are circulating in our blood that are also growth factors, but cause inflammation as well. And then, of course, there are lifestyle related inflammation. So a lot of different viruses can cause inflammation, chronic viruses like in the liver. Alcohol causes inflammation as well. There's unfortunately no safe level of alcohol. Even small amounts of alcohol have been associated with an increase in cancer risk, particularly breast and a few other cancers. And so this concept of having an anti-inflammatory diet, I think, goes hand in hand with having an eating pattern, a dietary eating pattern that in the long run supports a low level of inflammation. And that's typically achieved through what we've been talking about, plant forward, high fiber, and that helps to address a lot of these issues: inflammation, excess energy, insulin signaling, all through this one kind of dietary approach. Now, there are tweaks that we're working on in the research to try to improve that, reduce inflammation even further. But fortunately, we know that the dietary patterns we've been talking about accomplish a lot of these goals at once.
Thank you. And we're running out of time. And I just want to close by so quickly: sugar in one sentence. Should we avoid it when we have cancer or not? Like added sugar, Dr. Shaw?
I think very quickly, we should not think about all carbohydrates as the same. There's refined carbohydrates and complex carbohydrates. Complex carbohydrates like whole grains are associated with reduced cancer risk. And sugary drinks and things have been associated with inflammation, obesity, and increased cancer risk. So I think it's important to include complex carbs, but not the refined carbs.
Not the refined, and we're all in agreement with that. So can we just go through where does somebody go if they want to know more information about integrative oncology and integrative medicine related to cancer? And I'll go to each one of you. Dr. DeAndre?
So the Mayo Clinic, you can always go to our website. We've got lots of resources on mayoclinic.org. Okay,
and Dr. Eingard and Dr. Shaw, you're both at MSK. Do you have places that you can go, and can people follow you on Instagram or X or any of the social media? I don't think, are you doing TikTok these days or?
So just to add one thing, MSK actually has an app and a website called About Herbs, and that one actually has a lot of details on each of them and what the evidence is. So if patients want to know about like the cancer information related to any herb, then they can look that up in that website and app as well. So I think that's a really great resource. And then I post on social media on Twitter, Instagram, and LinkedIn through my first name, last name handle, which is Urvisha MD. So if anybody wants to follow or hear more about the work we do.
Yeah, and I'll just similarly, you can look up the MSK Healthy Living Program. It's a bit of a long URL, so I won't say it verbally, but if you just Google MSK Healthy Living, You can find some resources, links to resources there. I also try to, like Dr. Shaw does, we try to post our research findings on X or Twitter. My handle is at NEIL_Iyengar, IYENGAR. And then finally, I would recommend the American Institute for Cancer Research. AICR.org puts up patient-facing information. Every couple of years, they update it with the most recent evidence with regard to lifestyle research.
Wow. Well, thank you. Thank the three of you. I really appreciate it. And you taking time. I know you all see patients and are all really, really busy, and really thankful that you were able to fit this into your schedule. And, what a wonderful discussion. And thank you guys, and have a wonderful, wonderful day. And thanks for our audience. And you should stay tuned. We have some great food is medicine policy coming up with with Annette Nielsen, who is the executive director for the Hunter College New York City Food Policy Center. So please stay tuned for that coming up next.
For those of you just joining in, welcome to the Food is Medicine Summit. Next up, strategies for food is medicine policy.
For those just joining, we welcome you to our next panel, Strategies for Food is Medicine Policy. I couldn't be more honored to share the virtual stage with our three panelists today. Please welcome Dr. Brenda Ayers from Nuvance Health, Congressman Jim McGovern from Massachusetts, and Executive Director Natasha Pernica, who is from the Food Pantries of the Capital District, and more. Welcome, everybody. So we're going to start off with Congressman McGovern here. Congratulations, first off. I see we got a stopgap spending bill passed yesterday in the House, right? Averting a shutdown. Thank you.
Yeah, the government won't shut down for a few months, at least. Hopefully.
We love to hear it. We love to hear it. You've been serving in the House of Representatives since 1996 with a leadership role in the Rules Committee. You also serve on the House Committee on Agriculture. And through your advocacy, military families are now being screened for hunger. Schools are able to provide more nutritious meals. And America has a plan to end hunger within the decade. Talk about some current legislation, either on the national stage or more local, maybe on the state level, that underscores a dedication to nutritional welfare. As part of your answer, please talk a little bit, too, about how the Farm Bill has an impact on food as medicine initiatives.
Well, thank you for having me, and thank you for doing this. We're just getting started, and I'll soon reintroduce my bipartisan, bicameral, medically tailored meals bill to establish a national pilot program to expand medically tailored meals throughout the country. I just had a meeting about an hour ago with the head of CMS talking about actions I think they should be taking on this topic. And with regard to the Farm Bill, I mean, I think we need to make sure that we protect the recent update to the thrifty food plan, which is the calculation that determines how much people receive in SNAP. SNAP benefits, as you all know, are already way too low. It's about on average of about $2 per person per meal. Any further cuts would make it that much harder for people to purchase not just healthy food, but food in general. We need to increase and expand GusSNP, which is the program that provides additional money to purchase fresh fruits and vegetables, which has been a great success. We need to increase funding for SNAP education and nutrition education in schools. Making lessons about healthy food fun and engaging is a great way to foster healthy habits, and students bring these lessons back home to their families. If I had my way, I would be encouraging schools to teach nutrition and basic home economics, as they used to call it. I mean, I took algebra. I'm not trying to berate the importance of algebra, but I still don't know what it did for me. But nonetheless, being able to give young people the skills to know what is good for them and to also be able to prepare meals, I think is something that will last with them for a lifetime. The other thing is we are working state by state to make school meals universal and free and nutritious for everybody. We're working with USDA to deal with the issue of community eligibility so that more schools can get covered with federal funds. So those are just a few of the things that we're looking at. But that White House conference on hunger, nutrition, and health helped put out a lot of good ideas that people are trying to build on, and so we have a lot more to do.
That's really terrific to hear. And I attended that conference, and I've been, attending the listening sessions since. And it's really, encouraging for sure to have, these programs being worked on across the board.
And I would just say one other thing, and that is up to all of us who care about this issue to keep the pressure on our elected officials and on the White House. Hunger, when all is said and done, is a political condition. This is a solvable problem. But we need to make sure that our elected officials understand that it's an urgent matter and we need to push them.
For sure. I'm going to switch over to Dr. Ayers now. You've been a trailblazer as the inaugural medical director of health equity at Nuvance Health. Can you kind of outline for us some of the most effective ways to bring an equity lens to the table in the food as medicine policy arena?
Oh, I love the question, and thank you for this opportunity to be on this esteemed panel. I am truly honored. So I always like to think in terms of data, and we can dispute anecdotes, but it becomes very, very difficult to dispute solid data. And we have data that show that 6 out of 10 Americans in this country are living with at least one chronic condition like hypertension or diabetes. And many, if not most of these conditions are nutrition sensitive. And this means that the outcomes of these diseases are affected by what we eat, right? So when we look at the statistics on which populations are most affected by many of these chronic conditions, unsurprisingly, they tend to fall disproportionately along racial, ethnic, geographical, socioeconomic lines. And when we understand that the chronic diseases are responsible for 90% of our country's multi-trillion-dollar annual healthcare costs, the math actually becomes really, really simple. So looking through the lens of equity becomes necessary in order to understand what the most impactful ways of affecting these outcomes and cutting costs are for these conditions. And so for me, it follows that our policies addressing nutrition as a treatment for chronic disease, policies such as federal funding that Congressman McGovern was mentioning to support food as medicine programs, or policies that incentivize and promote collaboration between healthcare systems and community-based organizations, or policies that
expand these programs beyond Medicaid and some Medicare plans into the commercial payers. These are the policies that will require us to look through the lens of health equity to be most effective. And what the studies also have shown us is that when you focus on equity, the outcomes improve for all. And it truly is, rising tides raise all ships. So that's I think the way that I tend to look at this through the health equity lens and try to bring the conversation to others.
That's terrific. Thank you for that. Thanks so much. Natasha Pernica, you, through your work as the executive director for the food pantries of the Capital District and the Alliance for a Hunger-Free New York, and you're also a member of the New York State Council on Hunger and Food Policy. You've been working, really intensely in the realm of food insecurity, for sure. Can you talk a little bit about what you've seen, what you've learned, witnessed, particularly around SNAP benefits, before and after the enhanced benefits were ended, and how access to healthy food has had an impact on overall health of vulnerable populations?
Sure. Thanks so much, Annette. SNAP is our nation's #1 anti-hunger program. And so, yet, while I work with a coalition of food pantries, both in New York's capital region, but also across the state, we're here as a third line of defense. And I just need to throw this in that #1, we believe that living wages are the #1 way to end hunger. #2, it is SNAP. And Congressman McGovern talked about updating the Thrifty Food Plan. However, we, along with FRAC and Feeding America, strongly encourage our federal government to increase to the low-cost food plan in SNAP, which will increase the dollar amount, because we cannot just be feeding people food. It needs to be nutritious food, and we do know that nutritious food is more expensive. And I'm going to preface this with talking about a consumer survey that we did in partnership with Siena College for guests who are visiting food pantries for assistance, because there is some stigma about, or just misunderstanding about, what do people want to eat. People who visit food pantries, people who utilize SNAP, you hear a lot of stories. And when we surveyed consumers at food pantries, the items that they wanted more of were fresh foods. Meats, dairy, and fresh fruits and vegetables. So 10 years later, most of the food pantries in our coalition provide fresh fruits and vegetables. Now, going back to your question about SNAP and how that really has impacted our charitable food system through food pantries and food banks, when we were in the COVID times and there were a lot of federal assistance like child tax credits and the emergency SNAP allotments, we saw a significant decrease in the number of people who had to turn to a food pantry. This is important. We would much rather have people shopping at a grocery store like everybody else and having the dignity of choice in choosing the items that they're going to prepare for their own family through a grocery store, instead of having to use the limited supply chain of food banks and food pantries. So SNAP was a critical program to helping families and individuals get by during the COVID crisis. Unfortunately, now that SNAP benefits have been rolled back to pre-COVID rates, and the child tax credit ended, we saw a historic increase in the number of people seeing food pantry assistance. Here in New York's capital region, it went from about 64,000 people pre-pandemic down to 51,000. That's a huge drop because of federal assistance. That was a success. That's what we want to see more of. Now that that's been rolled up, we're back to 70,000 people, and this year we're even 15% higher than last year. So SNAP makes a huge difference.
It sure does. Thank you for that, Natasha. I appreciate it. Back to you, Congressman. Due to your advocacy work, you were really a primary reason why the White House Conference on Hunger, Nutrition, and Health took place last year. And when the 2022 task force report was published, What were some of the areas that required the most nuance in order to get enough buy-in from, your congressional colleagues?
Well, I should point out that the White House Domestic Policy Council actually wrote the final report. My job was to try to give them as many ideas and examples of successful, meaningful programs across the country working to end hunger for them to include. And so, I'm probably not the right person to be able to give you a definitive answer on that. My role in this was basically to give them the idea that we ought to do this conference. The last one was in 1969. So we landed somebody on the moon. And that resulted in a lot of important recommendations and a lot of important programs followed that I think made a difference for people. And so we tried to get this done during the Obama administration. We're not able to, and then we're able to then the Trump administration, I just kind of said forget about it, and then we went to we convinced the Biden administration to do it, and we get the congressional funding. We actually appropriated money to do this. Look, part of the reason why I thought this was important is, as I said before, hunger is a political condition. Mm-hmm. And, when you listen to some of the debates in Congress, or even when I do town halls back home, sometimes people say things that are not accurate in terms of why people are hungry, or even in terms of the benefits that are available to alleviate hunger. So I think we need to set the record straight, and we need to show what's working and what's not working, and what with a little bit more support, can work even better. So I think the importance of this report is that there's something in writing, and there is this, and it's out there basically to say that we can end this. This is a solvable problem. There are lots of issues that we're dealing with right now that I can't tell you what the solution is. But I think all of us on this panel would agree we can solve hunger, right? We can solve hunger. We can deal with the issue of the challenges of lack of nutrition. So this is about creating the political will to get Congress and state legislatures and local governments and businesses and nonprofits to focus and get this right. Hillary Clinton, used to say it takes a village. She's right, but it also takes a plan for the village to actually try to implement. And so, I think that's the importance of the report. The one final thing I'm going to say too is, one of the things I've been talking more and more about is the cost savings by getting this right. I would like to think that we would all be moved by the fact that there are people in our country, the richest country in the history of the world, who are hungry. I think the moral imperative to do something, to me, is overwhelming. That's not always convincing here in Congress, right? But, there are cost savings to be had if we do this right. And as I said, I was just at a meeting with CMS, and I explained to them that, the number of people who prematurely get who readmitted to hospitals after surgeries, the number one reason why is lack of nutrition. So why aren't we doing medically tailored meals? We talk about people with chronic long-term diseases that could be better managed or reversed in some cases with proper nutrition. Why aren't we focused more on that? You'll save suffering for the individual, but you will save a boatload of money. So, we just have to talk about this in a way that where everybody, no matter which angle they're coming at it from, understand that this is the right thing to do.
Yeah, bravo. Yes. For example, yes. So thank you. I think, Dr. Ayers, I'd like to bring you in on this next area. As a medical professional, and as a doctor, you've been witness to a lot of food as medicine initiatives regionally and nationally that have an expanded reach. And how do you go out and engage and build consensus with your colleagues in tangential areas? Let's say nurses, registered dietitians, lifestyle medicine practitioners, and health coaches. How do you build that coalition?
So I think this is a great question, right? There we go. You still see me?
Yeah.
Okay, not sure what happened there. I think this is a really great question. I would say as medical professionals, I think we're trained to understand information in terms of outcomes. And you're going to hear me, if you talk to me, you're hearing me talk a lot about outcomes. So when I'm speaking to my colleagues, I actually try to bring home the point in terms of outcomes. I think as healthcare professionals, that's what we really care about, right? We want to know that the treatments that we prescribe, the plans that we make for our patients actually result in a change in the condition, the outcome. And certainly, I think across the country, we now have several examples where food as medicine programs have made significant impact on outcomes for chronic diseases like diabetes or hypertension. You can look at Geisinger or Kaiser Permanente and what they're doing with their programs. The food as medicine programs have also been shown to reduce ED visits and readmissions. And these are outcomes that healthcare systems care about, right? Because they're incentivized to care about them. And what we've shown through these programs is that when people have regular, consistent access to healthy food, we can make a difference. Right? So that's one approach that I take is really tying it back to the outcome in a way that healthcare professionals can understand. The other technique that I will often use sometimes, I think resonates with people, is sharing my own personal experience as well. My lived experience in growing up, I grew up in the Deep South, and there were many occasions where food insecurity was a daily constant for us, where we didn't know where our next meal was going to come from. So I can offer a unique perspective as someone who's lived the experience and understands how the choice between healthy foods and putting gas in the car or keeping the lights on actually is not a choice. So you have no choice in those situations. And now as a physician, I understand the connection between disease and nutrition and how that plays out for vulnerable populations who often don't have the ability to choose to eat vegetables when the dollar menu at McDonald's allows them to eat something at least and keep the lights on.
That's right. Yeah. And especially with busy schedules too. I mean, if someone is working a couple of jobs to make ends meet, you don't always have time at the end of the day to think about meal prep, right?
Right.
So Natasha, in your work in community food, how has that informed your decision to kind of take this leadership role in launching, helping to launch the New York State Food as Medicine project? And when you started out, it was about a year ago, I think, maybe a little more. How did you go about identifying who was included in that process? And, speak a little bit about the importance of collaboration and really bringing all these people to the table in this work.
What brought the food pantries for the Capital District to the Food as Medicine world was the 1115 waiver disrupt here in New York State, where food was a part of the social care interventions. And as a coalition of food pantries, the first thing that I thought of is that food prescriptions should be as easy to access as a pharmacy. There's pharmacies on many corners, and I thought it should be easy. People shouldn't have to go to like a food pharmacy at a hospital in order to get the food. It should be in their own communities. And since we already had a coalition of food pantries across the region, we worked with our local care system on a concept for having medically tailored groceries, a cohort of organizations throughout the region, as well as medically tailored meals. And home delivery was absolutely critical because there are so many people that cannot get to a brick and mortar for so many reasons. So we launched our network approach to food as medicine solution in 2020, which was a great year to start something new, but we did get it done. And then we went through Distrip and we found that as a vendor, as a part of the 1115 waiver, the way it was set up as a vendor, in the social care intervention, we didn't have a lot of control over the funding or the program design, which was counter to what we had gone into it as. And so we felt, we're competing against a lot of other social determinants in, housing, transportation, access to primary care, so many other things. And so we really needed to come together as a food as medicine sector to advocate and develop best practices on the different models, because while medically tailored meals, prepared meals, has been around a lot longer, some people can cook. And so medically tailored groceries are a better option. And we wanted to make sure that we were pairing it with nutrition, education, and therapy, and registered dietetic nutritionists. So I drank the Kool-Aid, or maybe it was green tea. I don't know. That's a little healthier than Kool-Aid. But I really believed in this vision for food as medicine as a part of social care interventions. And so when we, got out of the DSRIP, didn't have a contract to provide the service anymore, and had to reach out to private foundations to fund this, I was like, the only way this is going to be sustainable for nonprofits to participate in this is if we're collaborating with each other. We need long-term sustainable funding through the healthcare system, through payers, through Medicaid, Medicare, private insurance. And we can advocate for what nonprofits need, but in order for this to be successful, we need doctors, nurses, dietetic nutritionists. We need the hospital system. We need the health insurance, the payers, and our colleagues at the government who are implementing the waiver and other systems. So we were grateful to be funded by the New York Health Foundation, and we launched the New York State Food as Medicine Project to come up with a long-term plan for food as medicine here in the state of New York, as well as recommendations for the new 1115 waiver that we're waiting on approval from CMS. So we brought together a group of over 100 people on this, including Dr. Ayers, from across the state, cross-sector, and have recently released our 1115 recommendations. But in the meantime, we've been providing feedback from our group to New York Department of Health, Social Care, so that we've been helping to inform, some of the project as it goes along. Some of the things that are so important is to make sure there is a continuum of care in the services. When someone comes home from a hospital, they might need medically tailored meals until they're well enough to then get groceries and so on. So we believe very strongly that there needs to be a continuum of services. This next couple of years, thanks to Elevance, we are developing a medically tailored groceries accelerator program here for New York State providers, because we need more research and data to show the outcomes so that we know, how do we prescribe it? What's the dose? How long should someone be a part of this program? And for us, it's always important that the entire household is served. If you are providing food to parents as a prescription through the medical system, I am a mother, I have 3 children, my children will be getting the food, and that won't impact my health. So it is so incredibly important for the entire household to get healthy food. For behavioral change for the entire family. So that's, and the collaboration is absolutely important, having recommendations that hospital systems, health insurance, doctors, dietetic, and nonprofits are all coming together in a consensus way to say, this is how we move this forward in New York State.
You guys have done a really great job. I've been really impressed watching the process and seeing, how you've really been in touch with every part of this system. It's great. Congressman, a couple of days ago, Politico published a piece about food as medicine. And, they were talking about, oh, it's so great. It's gaining steam, right? And they credited the work of the Bipartisan Policy Center Working Group, of which you're a member. And the article notes how, major companies and insurers highlighting Kaiser Permanente and Instacart are partnering to study how offering funds for California Medicaid beneficiaries to receive nutritious food to treat these diet-related conditions would have an impact, right, on outcomes. So, our takeaway here might be that around the cost effectiveness of these programs, but why do you think there's always a need to prove the economic side of food-related programs when, particularly in medicine, other treatments in healthcare are not held up to the same sort of standard?
Well, you're asking me to explain Washington thinking as somehow being rational or reasonable. It just isn't. I mean, look, I mean, we're faced with increasing deficits and debt. I mean, and we can argue why we are faced with that. I have my own views, which are different from the views of some of my colleagues up here. But it's always used as an excuse to do nothing. And sometimes we don't take the time to do the cost-benefit analysis. Again, as I said before, I mean, making sure people have enough to eat, have access to good, nutritious food, to me is a moral issue, right? We should be compelled to do this because it is the right thing to do. But in Washington, that's not enough. So you have to show that it's not going to add to the deficit or to the debt. And I think there are a number of studies out there that will back me up that this is a cost savings program. And I think within our medical systems, this would be a huge cost saving. We should be doing food prescriptions. We should, in addition to medically tailored meals. And I will tell you, part of the problem is Congress. Part of the problem is the medical establishment itself. I mean, there's that old saying, it's hard to teach an old dog new tricks. That applies to all kinds of systems that have been doing the same thing the same way forever. There are some hospitals that I can hold up as shining examples of integrating, food as medicine. I mean, Boston Medical Center in Massachusetts, I love, is wonderful. Some of the bigger hospitals are not so wonderful. When I meet with them, they yes me to death. They tell me, oh yeah, food is medicine. You're right. Yeah, everybody, we're all in agreement. But then you don't see any kind of real dramatic change in how they approach these issues. The science is there. The research is there. Cost-benefit analyses is there. What's missing is the political will. Is maybe shaking things up a little bit, doing things a little bit differently. I met with the mayor of New York before, who did a pre-conference at Gracie Mansion before we did the White House conference, and he told me about he had diabetes so bad he was told he was going to lose his eyesight and lose fingers and toes, and then he changed his diet and reversed his condition. I mean, I'm glad for him that his life is better because of that. Right. But the system has saved a boatload of money because he's not going to have all these surgeries. I mean, it's common sense. But we have to get people to do things differently and to take the steps necessary to do things differently. Because
it's sometimes hard, right? I mean, it's like hard to make those changes.
Right. But on this issue, there are cost savings to be had.
Right.
I mean, this issue, we actually save money. So I don't know what the hell the big holdup is. I mean, I'm not an expert on budgets, and I didn't do very well in math, but on this, making sure people have access to a healthy diet and access to healthy food on a regular basis will prevent all kinds of chronic diseases that will require a lifetime of care, and it will cost the system even more. So, let's just do what we know is right. And if that means shaking up some of the old-time thinking in the medical establishment, so be it. I mean, we should be teaching we should be requiring our medical students to take classes in nutrition, for heaven's sake. Like, why the hell is that such a big, heavy lift? And we're moving in that direction, but boy, it's 2023. I mean, we know more today than we did in 1950 about the importance of nutrition on health.
We'd hope.
Yeah, we hope.
Yes. So, Dr. Ayers, as we're talking about the medical system here, with your work creating the Health, Equity, Diversity, and Inclusion curriculum, you are contributing to the knowledge base of the new advanced faculty and residents, right? Describe how you incorporate a focus on the importance of policy and advocacy into your curriculum.
Yeah, it's another another great question. I would say that when I am looking or talking about policy and advocacy to the learners, it's not limited to food as medicine because there are so when we talk about health equity, diversity, and inclusion, it's all about policy and advocacy, you know, regardless of what the arena is. Specifically to the curriculum that I've developed, Health Equity, Diversity, and Inclusion curriculum, or we call it HEDI curriculum. As I've been developing the curriculum for our learners, what I've been extremely intent on is creating a longitudinal path for learning. I think, unfortunately, a common shortcoming of diversity, equity, and inclusion training is that it's often presented as a one-off or viewed as a one-off. I took this course today and now I'm certified in DEI, right? And when you understand the depth of DEI science, you realize that the one-off experience is not the best approach. So I focus my curriculum around foundational principles and pillars of health, equity, diversity, and inclusion. And we will spend weeks on each principle, moving from a macro level to a micro level of focus with the learners. And woven throughout each of those levels of learning is our themes and examples of the impact of policy and advocacy. I can give you specifically an example of work that we've done at Nuvance looking at clinical decision support tools like clinical algorithms and AI and how inherent biases in these spaces have impacted outcomes for marginalized patients across the spectrum. And with all these examples, I share with the learners how changes have been made through advocacy, primarily through advocacy, which have resulted in policy changes on the national level. I think about kidney transplant and the impact of the work around the EGFR calculator in medicine, looking at kidney function and disparity that the calculator we were using previously created for Black African American patients, right? And how that has changed through advocacy, changed policy, and again tying it back to the outcomes. This is what it means for that. This has a tangible impact on outcomes for our patients.
Great. Hey, all, we are at the end of our time. I know we could keep continuing talking. We didn't get to half of my questions, but next time, I hope we can do this again. So I'd like to thank you all who tuned in, and my deep gratitude to panelists here that you gave so generously of your time and your expertise. And I'd like to let everybody know, stick around. Up next, we've got culinary medicine training for providers. Thank you so much. Thanks. Have a good day. Bye.
Welcome to those just tuning in. Our next panel tackles the topic of culinary medicine.
Wow. Thank you, Dr. Ayers, Representative Jim McGovern, Natasha, Annette. That was a wonderful discussion on food as medicine and policy, and we really appreciate that. We're pleased to have you back. We're going to be talking about culinary medicine and the impact it has on our disease state. We have some incredible guests with us today. Christina Badaraco. I just destroyed that. Dr. David Eisenberg and Dr. Michael Fenster. Christina, correct me. How did I say your last name for me?
Badaraco.
Badaraco. So easy, and I messed it up. I wanted to start, right off the bat and talk about culinary medicine and what the definition is. We hear that term bantered around a lot. I'm starting to see it heavily in research studies. We do a news and research digest every week, and I'm starting to see that term come up so often in the space of food as medicine. Why don't we start with you, Dr. Eisenberg? Can you tell us what the definition of culinary medicine is and what we should know about it?
I don't know the exact definition. There are a few, but I think it generally looks at the combination of culinary skills, cooking, and medicine. How do you apply the features of teaching people to cook and bring them to a healthcare system, to combine them into something that helps patients make better choices, treat their illnesses, prevent their illnesses, reverse their illnesses? I think that's the general sense of culinary medicine. Chrissy, do you happen to know, or Mike, do you know the exact definition?
Well, I don't think there is one. I think there's as many definitions of culinary medicine as there are known as recipes for meatballs. So I think it depends. Certainly, at the University of Montana, we have a strict definition that we have to apply, and it's a little bit different in that our definition of culinary medicine involves looking at food through the lens of information theory and then applying that to a food health equation to maximize an individual's, in a positive way, their food relationships. So our viewpoint and our perspective is a little bit different than I think what a lot of people have been talking about earlier. We're looking at food as medicine and using it as a medical therapeutic intervention. So our definition and what we encompass and what we teach as culinary medicine is a little bit broader and more interconnected.
And Christina?
I appreciate the perspective we just heard. I think the definition that I've often heard and used is similar to what we heard from Dr. Eisenberg, the definition from La Puma back, I think, in 2008 about the blending of the art of cooking with the science of medicine.
So when I've looked at certain curriculum that have talked about culinary medicine, it's not exactly what I'm hearing right now. I've seen it looking to me more like nutrition education. And I just think that they're entirely different things. Am I right or wrong about that? Am I missing something?
Well,
David.
I would say, again, from our perspective and looking and analyzing, biological systems, which lend themselves to analogous information system analyses, that nutrition is one communication pathway. That is one way that food delivers information, which again becomes part of a food experience and builds an individual's food relationship. For our study of culinary medicine, there are many other channels through which important information that impacts health are delivered. So who we eat the food with, when we eat the food, where we eat the food, things that we can measure, things that we can't measure, all of these end up impacting the health equation. So for us, nutrition is very important, but it's one of many communication channels by which food and that food experience delivers information to our bodies, which impact our overall health.
And if we're talking, sorry, go ahead, Dr.
I was going to suggest that we go back a couple steps, because you're talking about the distinction between nutrition education and culinary medicine. I would argue that nutrition education is the bigger tent and culinary medicine is a part of it. Again, to give you some historical perspective, at the risk of oversharing, I come from several generations of professional bakers and cooks. But I went to medical school. So I'm a product of the two communities. And when I went to medical school in the dark ages of the 70s, no one knew anything about nutrition. And even the people who knew something about nutrition knew very little, if anything, about food or cooking. So, 40, 50 years ago, it was a gaping hole in medical education to talk about either nutrition or cooking. I think if you fast forward 40 years, people are realizing, number one, we do have nutrition science now, although it's rarely taught in medical school. And I think increasingly in dozens of medical schools across the country, and hopefully Mike and Chrissy will back me up here, medical students, residents, practicing docs are learning about nutrition and culinary medicine in an effort to teach them about nutrition and how to advise patients. So whether they're taking medical students on a tour of a grocery or bringing them into a makeshift conference room that's turned into a kitchen for a group medical visit, or they're going into an actual kitchen, large or small, brick and mortar or virtual, they're learning about food and how to advise patients about food. And the last thing I'll say is I think increasingly people are sharing of the opinion that teaching health professionals or patients about nutrition and food in the absence of a teaching kitchen is like teaching kids and adults the value of swimming in the absence of a swimming pool. How do you do that? So there has to be a practical, experiential component. That's where culinary medicine comes in.
That's great. So I'm gonna go right back to you because, and I've been looking at this for quite some time. So a teaching kitchen, right? And I would ask you, is a teaching kitchen is that something that you're putting in a hospital that patients are going to learn from physician chefs like Chef Dr. Mike, or are they and from dietitians and from chefs, or is that something where medical school students are these teaching kitchens are in medical schools and medical school students are going into these kitchens after they've had their basic nutrition education courses and now learning how to apply that so that they could teach patients and understand when they're giving patients advice that, hey, when you need to cook it and it needs to be cooked this way, and this is how you, and when I tell you should be adding more broccoli, by the way, make sure you use this because I've done it before. And all three of you should jump in here. So we'll start with you, Dr. Eisenberg.
Well, to me, a teaching kitchen is more than a kitchen. I view it as a learning lab, a classroom for life skills. I think the kitchen part of it is the attractive piece. It's the neon light. People increasingly want to learn how to cook because they've lost that skill. And 3 generations of people out working and grandparents not living in the home, people are fascinated. So if you say, come in the kitchen, we'll teach you how to cook. But it's also a place to learn nutrition facts. Which foods should we be eating and cooking? How to cook them, how to shop for them, how to read labels. In my view, and the view of members of the Teaching Kitchen Collaborative that I helped create, people also say, if you've got them in the kitchen, you're teaching them nutrition and cooking, teach them about the importance of movement and exercise, of rest and sleep. Teach them how their food choices impact the environment and sustainability of the planet. Teach them to eat and cook and live mindfully. Because if they're not mindful in their cooking and shopping and eating, they're lost. And lastly, there's 50 years of psychology literature that I didn't learn in medical school, but motivational interviewing is now a thing in medical schools. And if we teach people to focus on what motivates them to change, it helps them change once they learn new skills. That's a teaching kitchen. And it can either be brick and mortar and expensive, or it can be 2 $8 tripods with an iPhone on the hands and pans and the face of the chef educator and people on a Zoom call, or it can be a $5 million teaching kitchen. So it's all of those things. And maybe the bottom line point here is a teaching kitchen is more than a kitchen, and culinary medicine is a part of a teaching kitchen, but they're not the same things.
That's great explanation. And Christina, Mike, anything to add to that?
Sure. Well, I think one other aspect to add to the detailed description we just heard that I particularly love about teaching kitchens is the way they create and build community among patients and participants, bringing people together to enjoy learning and cooking together, and creating some of the social norms around healthy eating and enjoyment of healthy food that we know is so often hard to come by. There's often sort of a negative perception about healthy food, and cooking can be a barrier, almost like a punishment. So I think by sort of building community and creating space for that, teaching kitchens can really help to make cooking and healthy cooking a more enjoyable experience. And again, create some of those social norms. And maybe another area too is helping to break down some barriers between the patients or participants and their healthcare providers, dispelling with some of the white coat syndrome or even hesitancy. I'll speak for myself as a dietitian. I think there is sometimes still hesitancy about being necessarily truthful about what patients are eating and maybe accurately portraying the sorts of things that they do eat. But I think people can bring down some of those barriers and be a lot more comfortable in a teaching kitchen setting.
Christina, when you were talking, I had this vision of a new version of a examination room where there's actually it's in a kitchen, and after they talk to the patient, they examine them, then they sort of do like a little recipe, shared recipe with them. Again, my imagination was running wild, but.
Well, we might have a chance to talk a little about the shared medical appointment format, but there is kind of an option for what you just described. Go ahead, Chef Dr. Mike.
Yeah.
I was just going to say, number one, take this opportunity to thank David. I don't know if everyone realizes the phenomenal work he's done in bringing this whole concept, to fruition and reality. So a quick thanks to you, David, and a bit of acknowledgement. And I want to highlight on two of the things that both David and Christina mentioned, which was the experience. And that's one of the important differences when we look at food and applying food as medicine or food with a healthcare direction, is the fact that it's unlike taking a pill or getting your bone set and fixed or getting a pacemaker and coming in for that procedure. It's an experiential, and I think David was the one who used that word, part of our lives, which is very, very important and introduces a whole set of variables, opportunities, and challenges that are different from how we normally approach, treating disease and even chronic disease, in the confines of Western medicine. So I think, David's description and Christina's description of the teaching kitchen is spot on, and I think it really is sort of a segue to a future environment where we can really impact lifestyle type things, and I think that's very important as we discuss the impact, both personal and economic, in terms of chronic disease and the epidemics we face.
That was great. And then I think, one of the things that we had been talking about is how there could be future career paths in both cooking and medicine combined, right? People that are experts in doing that. And it doesn't have to be just docs. It could be, it could be registered dietitians, it could be nurses, and they could, right? I mean, is that kind of how you guys are all envisioning this? Or
let me jump in here. The educational ensemble of a teaching kitchen can be one person or six people. And it depends on how many. Do they know about nutrition? Can they teach people to cook? Can they teach people to be motivated to move more? Can they teach people to be mindful? And can they teach them to change their behaviors? But if you have an MD chef or an RD chef or a PhD in behavior who's a chef, they can do most of that themselves. So we have lots of examples, Chrissy and Mike and I, Mike's an example of a dual trained expert. Chrissy is also a very expert in multiple aspects of that ensemble. But in a teaching kitchen, people are there to learn, how do I eat and cook and move and think differently? And to their point, when you have a team that's teaching them and it's fun, it's addictive. People just have a blast, whether they're medical students, patients, continuing ed graduate groups that are coming there to learn, as we do in Healthy Kitchens, Healthy Lives, a course for doctors every year. Or the ultimate place for these things is actually schools, to bring back Home Ec 2.0. Could you imagine if there were teaching kitchens in every K through 6 and K through 12 school, along with every college campus, along with every work site? That's kind of the vision, the aspirational vision, that people will come together to cook, to learn a different relationship to food, and have fun. So I know I'm speaking in aspirational tones here, but the teaching kitchen can be applied to all of those spaces. The facts are the same. It's just, how do you package it for different population? That's why I think it's a big idea.
And that's and I agree, and they should be, and they should have, maybe not called home economics, but certainly, you know, learning cooking and lifestyle skills would be incredible. But shifting, and not really shifting, but segueing to medical school students and medical education. I know that the congressman had talked about some of this previously. And Dr. Eisenberg, you had some thoughts about the impact of some of the legislation on medical teaching and so forth. Can you talk about that?
Yeah, let me speak to that for a second. I think 30 years from now, if teaching kitchens have the impact that I think they're destined to have, Jim McGovern will go down as the pivotal figure that changed everything. And I say that because he single-handedly advocated for and then passed a bipartisan resolution in the House of Representatives that says either the medical establishment mandates, requires physicians and medical trainees to learn about nutrition and how to advise patients about food, or Congress reserves the right to withhold now $16 billion a year in educational funds for residents and fellows in hospitals.
Wow. So what does that
existential threat?
But what does that translate to? Or so what's happening as a result of that?
Sorry?
So what's happening as a result of that?
Hold on a second. I can't hear you for a second. Go ahead, okay. Charles.
So you hear me now?
Yeah.
Okay. So I said, what's the result? What is happening as a result of that in medical?
So there was a nutrition education summit hosted by the Accreditation Council of Graduate Medical Education and the American Association of Medical Colleges last March. Because, you know, this is the funding they use to train the next generation of docs. And what came out of that is an ongoing project that I'm a part of with the Teaching Kitchen Collaborative and the Accreditation Council. Instead of looking at all the existing curricula and all the teaching kitchen programs in the country, the idea was, let's create a consensus of competencies. What competencies do we want every doctor to have and demonstrate moving forward? So we're in the midst of determining a consensus on the competencies. That series of surveys has been done. I think there will be an article submitted next year for publication. But could you imagine if we get to the point where medical schools and residencies agree that these are the competencies, and then the curricula follow the competencies, and nobody is fighting about my curriculum is better, but we're all in line, we're all rowing together saying, okay, from now on, medical students need to be able to do this. Residents in these specialties need to do this. And practicing docs need to update their skills in nutrition and advising patients about food this way. That's the future. But that was all Jim McGovern. Wow. And when that happens, then doctors are part of the solution, not the resistance.
It's a huge change. So now we're going to see more people like, you know, like Chef Dr. Mike and more dietitians like Christina that are out there and sort of focusing on this as a solution to healthcare. Is that and
I think so, and that was Representative McGovern's ambition to push the medical establishment, because I was in the room when he learned that doctors are not required these days to know very much about nutrition and even less about competencies in talking to patients about food. And he said we have to change that. So that's why I think, again, in retrospect, a decade from now, he'll go down as the champion.
Wow. And Mike, what does it look like in a practice? Okay, you're a cardiologist by training and also a chef by training, so the two are right up there. And who knows what you love more? But what does that look like? How are you? Let's hear about a patient, not a made up patient, and how this translates into what you do.
Well, one of the kind of interesting evolutions is that how we've approached and integrated this really parallels a lot of how we do interventional cardiology. So not far behind David in the dark ages of medical school, when I first got out as an interventional cardiologist, I made a decision. Patient goes to surgery, patient gets an intervention, etc. And really fast forward, decades later, and that is really done through what we refer to as a heart team. So instead of fighting with the surgeon, we work with the surgeon and we all have inputs and we decide what's best for the patient. And it's really shifted this into a patient-centric team approach. And that's what we do. So I work with professional chefs. I work with professional dietitians on the team. I also work with, and I think both David and Christina alluded to this, people to address behaviors, right? Because food is unique in terms of applying it as a health therapy or getting people to eat healthfully. We have to understand what motivates an individual to choose certain foods. We hear all the time, you are what you eat, but we also eat what we are. And so we have to understand that if we're going to change behaviors, and in addressing chronic disease through food, really that's what we have to strive for. And a team approach, a supportive team, it's much like, to draw an analogy to cardiology, it's like getting people involved in cardiac rehab. Right? At the beginning, it was like, you're crazy. Somebody's had a heart attack. They got to lie in bed for 8 weeks. Now we're getting into the gym and they're involved in group programs and they love it. And when the government stops paying for their cardiac rehab, they're signing up and they're living healthier, more vibrant lives. So that's, I got a little aspirational too, David. You're infectious, but that's where I see it going.
Well, Mike, you're alluding to the fact that teaching kitchens and culinary medicine are part of a wellness team of the future.
Yeah, right.
They're Absolutely. A wellness team.
And Christina, where do dietitians fit in here? I know you're a registered dietitian. By the way, just the audience knows that Christina just gave a lecture, or was it a panel at American Public Health Association? Is that correct? And that's where you are right now, correct? In Atlanta?
I am, yes. Coming back to DC soon, but I was giving a roundtable discussion the other day about looking at opportunities for better coordination between food as medicine interventions that are covered by Medicare Advantage and Medicaid plans, and then some of our federal nutrition assistance programs like SNAP and WIC. So my first time at APHA, it's been a wonderful opportunity. To answer your question, I think what I was thinking as Dr. Eisenberg was speaking a minute ago, I think sort of partially at least inspired by some of that work he's describing with physicians and competencies. There's actually a group of us who, in the nutrition committee with the Teaching Kitchen Collaborative, who have been working in recent months thinking about how can we replicate that effort, or not necessarily replicate, maybe adapt and pursue that effort for the dietitian community. There are certainly many of us who are passionate about culinary medicine and this field, but we think that there is certainly need for building more culinary skills among the registered dietitian community. And there are, I think, a lot of opportunities to be able to use the skills and the passion and expertise that we have. But I think we could, our field, our profession rather, could benefit from competencies and more opportunities for training and education. So several of us have really, I think, been enthusiastic about spearheading that effort as well.
And what about the specifics, in terms of, getting down to some of the granularity of teaching, of using, food as medicine, or not in conjunction with pharmacological treatments and things like that. And when you're thinking about this, about food as medicine, and thinking about teaching kitchens and thinking about culinary medicine, are we talking about specific things? Sorry about that. Are we talking about specific things like, we need to make sure we have more salmon in the diet with omega-3s and with DH? Go ahead, Mike. You're shaking your head. Jump right in.
Yeah, I was going to channel Dr. Graham from earlier, and Dr. Drew as well, and really say, one of the things that we have to look at is the amount of ultra-processed food we consume in this country, almost 70% of the diet, the timeline of that, how that correlates to chronic disease. Lots of studies out there looking at that, especially in terms of NOVA classification, which is often not used in this particular country, though it's been adopted by the WHO and many other Western countries around the world. So I think it's less about specific foods and actually getting simpler, right? If we want people to eat things, what are one of the main drivers? Yes, nutritional knowledge is important, but like the food has to taste good. And I've yet to really hear people talk about that today. Life is short. I enjoy food, obviously. I love to eat delicious food. So the food has to be delicious. And I think we can keep it simple and look at real foods and show people, and this is where a lot of the culinary chefy aspect of what I do comes in, which is showing, as David said, people how to cook. We're losing that skill. We're becoming dependent on convenience culture and ultra processed foods. And so I'm not a big believer in this superfood or that superfood. I'm a big believer in real authentic food.
That answers that question. Sorry, Dr. Eisenberg.
I was going to just build on what Mike said. Healthy, delicious food is not an oxymoron. And although the media loves to pick up on where the nutrition experts disagree, but 90% of nutrition experts agree on 90% of the issues. If we ate less processed food, if we ate more fruits, legumes, beans, nuts, vegetables, if we had less processed parts of our diet and less sugar sweetened beverages, we would all be so much healthier. We would save so much money. And if people knew how to cook them, they'd realize it's not more expensive than going out to a convenience fast food restaurant. It's much more delicious, and eating with the people you love, who you've just cooked a meal with, is always better. So that's part of what's pushing this movement forward. And I just want to build on what Chrissy said so that there's no confusion. It takes the team. And this is where dietitians and chefs and physicians and behavioral scientists and environmental advocates come together and say, how do we create a different relationship for our kids and the teens and 20s of the world to make it better, healthier, and more sustainable? That's the future.
And I just and thank you for that. And that's true. And quite frankly, one of the things that I wanted to bring up was about hospitals. And I guess when you said the $5 million teaching kitchen, I had this fantasy that it's in some killer hospital. Not killer. That's a really bad term. Sorry about that. Retraction. Some incredible hospital that sort of has this teaching kitchen in there, and patients are coming in, they're wheeling them in, they're teaching them how to cook. Diabetics and heart patients and everything else and the like are in this kitchen, and there's lectures coming in and people teaching them, and there's hands-on approach. Is that a fantasy? Are there hospitals like that? Because one of the things that
there are, and UCLA, UC Irvine have multi-million-dollar gorgeous teaching kitchens. But increasingly we're realizing after they were built, if you view them as broadcasting studios, they can reach 100,000 people. Right. You just put cameras on the chef's hands, face, and you have all the other experts on the Zoom call. We now have scientific studies around the world, no less, that say teaching people virtually in real time, where the chef is watching 20 students on a monitor, can be as effective as having the 20 people in the kitchen. So maybe we won't need the $5 million teaching kitchens, or when they're built, they're envisioned as educational platforms and broadcasting studios, not the be-all and end-all of the teaching kitchen world.
Well, I can't believe it, but it's actually already been almost 40 minutes, and we're wrapping up. And I just want to thank the three of you for coming. And Mike, what are your social media handles, and what can people look at that you're doing? I know that you just started writing an article for the Center for Food as Medicine each week, analyzing analyzing a study each week, which is incredible. So you can look for that on foodmedcenter.org. But what are your social media handles, and how can people follow you and reach you?
So just look, it's Chef Dr. Mike, as is on the screen. And I encourage folks, if they'd like to learn a little bit more about our approach, you can view my recent TED Talk. So that's on TED.com. And yeah, just look for Chef Dr. Mike. And I'm not rich and famous celebrity chef, so I have to do all my own social media. So contact me. I'd love to hear from everyone. I'd love the input, but give me a day or two to get back to you.
And just one quick note: his wife is an incredible food photographer. So thank you for that. And Dr. Eisenberg, how can people reach you, follow you, read anything that you're writing?
I think I will mention that I was the external editor of a series of papers in the journal Nutrients that just published 23 or 24 papers on teaching kitchens. Excellent, all published in the last 5 months. Read them. I co-authored or authored 3 of them. And, the Teaching Kitchen Collaborative, which is teachingkitchens.org, tells a lot about the work I've been involved with for many years.
Right. Well, and Christina, how do we reach you?
Sure. Well, and to reiterate the nutrient supplement, I had the pleasure of publishing an article in collaboration with David to describe Teaching Kitchen. So that might be a great resource for the audience as well. I do have a personal website, ChristinaBadaracco.com. If folks would like to learn more about my work in food as medicine, culinary medicine, sustainable ag policy, and also on LinkedIn, I think would be great as well.
Wonderful. Well, thank you all. I look forward to sort of getting this group back together, and having a recap in a short time, and spending a little bit more time with everybody. So thank you so much. And we're going to have our closing remarks, which are only about 2 minutes. So stay tuned. We'll be right there and right on. And thank you all, and have a great day. Wow, that was incredible. And as the curtains close on the Food as Medicine Summit 2023, Treating Disease, I'm filled with a sense of gratitude and inspiration. I mean, what a great job everybody did today, and really pleased with all the panels. Annette, what'd you think, and where are we? And
Thanks, Charles. Similarly, I was really left inspired by all of the panels, but I do want to do a shout out, our immense gratitude to the production talents and technical support from Patrice at Buzz Productions and Brendan at Konaki Media, and many, many thanks to our staff at the Hunter College New York City Food Policy Center, Sycamore, Anna, Marissa. We could not have done this without you, and we so appreciate Gabe and John, our designers, and a special shout out to Shannon for her outstanding voiceovers. And Alexina, what do you think?
What an incredible day. A huge thank you to all the panelists, our audience, and everyone who contributed to making this event successful. I was really moved and excited by everything we heard today. Remember to stay connected with us by subscribing to the Hunter College New York City Food Policy Center's weekly news digest at nycfoodpolicy.org and the Center for Food Medicine's weekly news and research digest at foodmedcenter.org. Annette and Charles, I know you guys have some really exciting events coming down the pipeline. Annette, what's going on at the Food Policy Center?
Yeah, we'll be hosting an in-person panel discussion on urban agriculture next month at the Hunter College Silverman campus in East Harlem. And also look out for the Center for Food as Medicine's upcoming panel on dietary supplements this January. Charles?
Thank you, and thank you. And just as a reminder, it's nycfoodpolicy.org and foodmedcenter.org. That's where you can sign up for those newsletters. On behalf of all of us here, thank you for joining the Food as Medicine Summit 2023. And thank you all.
Thank you.
Stay healthy.
Thank you. Stay healthy.
And have a great rest of the week.
Yeah.